Folks, I sincerely want to thank everybody for participating. This is a labor of love, nothing else, and all of you are greatly appreciated, and looking forward to your talks. We're going to learn some interesting things today. Particularly want to thank Erin for running the meeting. She's lowered my stress level considerably. If the meeting works and is successful, it'll be entirely due to Erin and her organizational skills and efforts. Just want to remind everybody what we really like to do is not just present the papers, but discuss them and for a bit. And so everybody, if you can, try to kind of keep the presentations concise and so that we have time to talk about them. At the end of the meeting, we'll stay on for maybe a half hour tops if people just want to talk about various things, and there's still some discussion that we need to have. We're also recording this meeting so that it'll be put on the website. So you'll be able to tell friends about it, look back at it later. Also, don't worry about if you have to feel like you're going through your slides a little quickly, because the rest of us can go back and look at them at our leisure and get any information that kind of gets passed over quickly. So with that, I want to introduce Andrii Korol from Ukraine. Especially appreciate Andrei's participation and that of his colleagues. He's the only one in the group who's actually working and doing this presentation in the middle of a war. And I can't imagine what that requires and what it's like, but it's incredibly impressive, and really admire Andrii for what he's doing and all his colleagues in the Ukraine. So Andrii, go ahead and thank you.
Yeah, dear Jeffrey and colleagues, thank you for the honor to be the first presenter here. And of course, thank you so much for invitation. So let me introduce results of our research of interaction of laser and the RPE. Sorry. Okay, another slide. So currently we have several types of coagulation techniques for different purposes in the retinal pathology. All these techniques have different types of interaction of laser and RPE, but micropulse laser has the most delicate impact on it. Okay, and in the end of 80th of the last century, Pankratov invented a new laser mode in which laser energy is delivered in short pulses, like micropulses. This allowed a selective effect on the retinal pigment epithelium and avoiding damage of the neurosensory retina. And in 1992, Bernd Gruber and his colleagues further reduced damage to photoreceptors and other intraretinal cells by shortening the microsecond pulses even more and targeted the RP, and selective retina therapy was born. So what we know about interaction laser RPE? We know that RPE cell contains melanin granules, mostly in the apical part, and we may use this knowledge in the mathematical modeling of the interaction laser RPE. And during conventional laser photocoagulation, laser energy is absorbed by apical part of the RPE. After absorption, temperature of RPE, retina, and choroid increases rapidly and leads to coagulation of tissues. This coagulation we see as formation of white lesion during panretinal coagulation, for example, or classical stages of laser burns accordingly of L-esperance. Mathematical modeling of thermal interaction by Professor Semenyuk says that the maximum heating arises within pigmented part of RP cells, since it's the most absorbing tissue in the eye. The adjacent to RPE, sorry, I have no. Okay, the adjacent to RPE neuroretina and choroid become involved into the heating process due to heat conduction from RPE after a pulse width of more than 10 milliseconds. And hence, for long pulses, thermal damage of the photoreceptors at the outer neuroretina can take place along with RPE photocoagulation. In microsecond range, pulses widths of 10 microseconds and less, the heated zone is localized predominantly within RPE. So when we need to coagulate some tissues, melanoma, feeder vessel, or panretinal photocoagulation, we use single millisecond exposition for maximal collateral damage. If we want to preserve the retina, we need to use microsecond exposition. But single microsecond exposition is not enough for therapeutical effect. So we have to use repetitive microsecond expositions. This is illustration of the temporal temperature profiles in eye tissue during laser irradiation and after pulse termination. There is 3 points are considered: the point with maximum temperature within RPE, RPE retina boundary, and that with pulse duration 0.1 millisecond. The temperature rise is almost 10 degrees Celsius lower than the maximum heating within RPE, what provides good conditions for selective RPE coagulation without damage to photoreceptors. It's seen also that even for duty cycle as small as 5%, a considerable overheat remains at the end of the cycle, and this effect increases with pulse repetition. Also, on the base of this mathematical modeling of laser RPE interaction, we conducted following experimental research. We had 3 groups of rabbits with 130 577 nanometers, and control group with conventional coagulation. All animals underwent biomicroscopy, ophthalmoscopy, electron microscopy of the chororetinal complex the next day, and 14 days later laser impact. We used the following parameters of micropulse laser coagulation and calibration of power along the myelin fibers until the appearance of a burn of the first degree according to Ellis-Brans in the micropulse mode. But the power of the effect was reduced by 25%, 50%, and 75% for the next coagulation. So we not visible coagulation, subthreshold coagulation. And another 2 groups with 532 nanometers conventional coagulation and 577 nanometers photocoagulation until the appearance of a burn of the first degree according to Ellis-Brans. And our results. So this is electronic microscopy 1 day after threshold impact of 532 nanometers and 577. They were almost equal, and we see absence of RPE level, RPE layer, sorry. In some places, rupture of RPE cells. In the interoceptor matrix, fragments of cells of the outer and inner segments of photoreceptor cells. Another group, 1 day after micropulse and exposure at a power of 25% of the threshold effect. Was found normal ultrastructure of choricapillary endothelial cells and the retinal pigment epithelium cells, and area of normal structure of photoreceptor cells. You see almost normal outer segments, inner segments of photoreceptor cells. Another group, 1 day after micropulse, 577, at a power 50% of the threshold effect. We may see destruction it was found destruction of the apical part of RPE and external segments of photoreceptors, but it was normal ultrastructure of the cytoplasm and nuclear structures of photoreceptor cells, and normal structure of the base of RPE cells. So apical parts was destructed, but base parts, it was almost normal, and the nuclei of RPE cells were normal. Okay, another group, 14 days after 577, and power 50% of the threshold exposure. So we found the usual photoreceptor ultrastructure, atrophic changes in the cytoplasm of pigment epithelium cells, and the organization of the apical region with a large phagosome. So 14 days after this exposure, we found a restoration of RPE cells and photoreceptors. And last group, 1 day after Micropulse 577, with power 75% of the threshold exposure, disintegration and decay of pigment epithelium cells with damage of photoreceptors, outer segments, inner segments, and even bodies of photoreceptors. And 14 days after Micropulse, with 75% of threshold exposure, also localization of cytoplasm and the destruction of the apical region of the pigment epithelium. And so this exposure didn't let restore the RPE cells. So we found partial destructive effect of 50% of the threshold power. So when we use it, was destructed apical part of the RPE cell, but remained nuclei of RPE cells. And after 75% of the threshold power, we found complete destruction of RPE cells. So when the choroidal retinal complex is exposed by 577 nanometers, laser radiation by a series of pulses with microsecond exposure, with the radiation power in the micropulse mode, and using 50% of the threshold power, damage occurs mainly to the apical parts of the RPE and the outer segments of photoreceptor cells. Compensatory and restorative processes in the cells of the retina lead to restoration of ultrastructure of the apical parts of the cells of RPE and segments of photoreceptor cells, which is observed up to 14 days after laser exposure of micropulse yellow laser. When changing the power of yellow laser with microsecond exposure, there is a selective damage of the structures of choroidal retinal complex. Thus, when we're using 25% of the threshold power, minimal damage occurs to the apical part of the RPE cells. When we use minimal damage, and when we use 50% of the threshold power, damage occurs mainly to the apical part of the cells of the retinal pigment epithelium and the outer segments of photoreceptor cells. When using 75% of the threshold power, damage occurs all cell parts of the RPE and photoreceptor cells, including the nuclei of these cells. In the discussion, I may say about Berngruber, they investigated the mechanism of the selective RPE damage induced by repetitive microsecond laser pulses in rabbits. They noted that selective damage of RPE with sparing of adjacent structures can be obtained with laser pulses shorter than the time needed for heat conduction to spread temperature rise to adjacent sites, but long enough to induce damage to target structures. And Jeffrey Luttrell and Chang compared the safety and efficacy 810 versus 577 laser wavelengths for micropulse subthreshold laser treatment by mathematical analysis and kinetic analysis of laser-induced heat shock proteins activation shows that the primarily therapeutic effect of laser is a thermal incitement of a long-term wavelength independent increase in the rate of HSP-mediated protein repair specific to sick and dysfunctional cells, rather than from short-term increase in free intracellular HSP concentrations. So in case of using 25% of the threshold power of yellow micropulse laser, HSP-mediated protein repairing may play a main role in damaged tissues. In conclusion, there is possibility of different types of interactions of yellow micropulse laser with RPE. We may set level of damage of RPE cells from stimulation to partial damage of apical part of RPE cell and to severe damage with different percentage of threshold power. I call it sculpturing of the RPE. And this may be used in clinical practice as laser treatment approach with the least invasive effect on chororetinal complex. Thank you for attention. Dziękuję za uwagę. Thank you again.
Thank you, Andrii. Can everybody hear me?
Yeah.
Sure.
Yes.
Okay, great. We're don't have really much time for discussion. I have a quick question, Andrii. When you say that at a certain exposure, the RPE cells regenerated and so on, can you tell from the EM whether those are injured cells that are kind of healing, or are those RPE cells that are sliding to fill the gap? In other words, if you blow off the top apical portion of the cell, is the rest of the cell able to heal and recover, or are those cells die and then they're replaced?
We analyzed this data, and our opinion, when we use 50% of the energy restoration of this partially damaged RPE cell, because nucleus of this cell is sorry, forgot this word. It was okay. It was inside of the cell, and because of this nucleus, the cell may restore it. But if you use 75%, you destroy the cell completely, and it may be replaced by other cells.
Okay. Well, thanks very much. We may have a chance to talk about this more later on, but we've got to move on to Dr. Paulus and his colleagues. Nanosecond laser synchronized with ultrasound for treatment of choroidal neovascularization. Yannis?
Hi, everyone. Can everyone hear me okay?
Yes.
You can see my slides? Good. Well, thank you very much, Jeff, for the opportunity to present. And thank you very much, Aaron, for coordinating everything. So I'll be speaking today on using nanosecond lasers synchronized with ultrasound, specifically for the treatment of choroidal neovascularization, or CNV. And I'm at the University of Michigan Kellogg Eye Center. For disclosures, I do serve as an inventor on 10 University of Michigan patents. 3 are related to what we'll be discussing, have co-founded some eye companies, 1 related to what we'll be discussing. The other ones are unrelated. And of note, we will discuss preclinical systems not approved for human use. So for photomediated ultrasound therapy, the concept of it is concurrent nanosecond laser with ultrasound and synchronized with ultrasound. And by doing this, we could selectively treat blood vessels non-invasively, unlike, for example, photodynamic therapy where you give a intravenous dye. There's no dye in this case. And you can actually, by changing the wavelength, select whether or not you want to treat an artery or vein. Current treatments, as we all know, have many disadvantages, including the fact that they're invasive, they have to be given frequently, they can result in permanent scarring. So really what we want to do is make a new treatment that reduces these disadvantages. Excuse me. So I'll refer to it as PUT, or photomediated ultrasound therapy, this synergistic application. And it's thought to be based on the photoacoustic effect, where you get the promotion of microcavitation bubbles in the targeted vessels, and then the shear stresses and microjets produced by this microcavitation can result in vasocontraction, blood clot formation, and hemorrhage if you use higher intensity PUT. This is a schematic of the system where you have the laser and ultrasound synchronized. We typically are using about 5 nanosecond pulse duration laser. Currently, we have a 10 hertz system, but obviously you can make this much faster by increasing the rep rate of the laser. You have a delay, function generator, and amplifier to make sure that your laser and ultrasound are synchronized at the same time. We started on chicken yolk sac membranes to actually show that we could selectively treat arteries versus veins. On the yolk sac membranes, the arteries and veins are reversed from what we typically think about in terms of their oxygenation, with the veins being high and the arteries being low in terms of the oxygen saturation. So this shows that you can actually controllably treat single blood vessels using this treatment. These are our ultrasound and laser parameters that we're doing. At laser or ultrasound only, we're actually using things below the safety window such that we're actually getting no effect at all. It's only by this synergistic, synchronized application of laser and ultrasound that you actually get an effect. And so it's only at this higher PUT, the 4 and 6 millijoules per centimeter squared, that you're actually seeing this sort of synchronized PUT effect, whereas at the lower ones, you're seeing no effect at all. By using different wavelengths, you can actually select if you want to target oxygenated versus deoxygenated hemoglobin. And as I mentioned, this chicken yolk sac arteries and veins are reversed to how we typically think about it. And I'll show a video, but here you can actually see that we're seeing a shrinkage of the vein, whereas the artery here is unaffected. And so this is a video, the veins on the top, the arteries on the bottom. You'll see that the artery is unaffected throughout the treatment, and the vein is shrinking over the course of the treatment itself, such that it has greatly diminished amplitude. And you could sort of demonstrate that here using 578 nanometers, seeing that the vein is affected, the artery is unaffected. But if you change the wavelength, you can actually selectively treat arteries if that's your desired goal. So here you actually see in the artery, what you actually see is a clot forming. So here you have the artery on the bottom, the vein on the top. You'll see that the artery distally is actually shrinking. You'll see it shrinking to the point that actually you get an occlusion of the blood flow. You can literally see the pulsating of the artery without actually seeing blood flow here, as you get a complete occlusion of the artery in this region right here that you're seeing, where there's no further blood flow beyond that because you're getting occlusion of the artery itself. And this is a quantification of that. If you use higher intensity PUT, you can actually rupture the vessels, but at lower intensity, you form this clot in the arteries. One of the big advantages of this is thinking about macular treatments is the safety window. So with conventional laser, we typically have 3 to 4 as the safety window. With this, it's an order of magnitude more, about 20, because of the fact that you're using laser and ultrasound that are far below what we would typically use in terms of the fluences, because you're using this synchronized laser and ultrasound. This is our investigation into the mechanism of action, showing that it's the photoacoustic effect of this microcavitation bubble formation. Where you see with ultrasound and laser only, you get rare microbubbles forming, whereas when you have the synchronized laser and ultrasound, you have blood right here, and you see these white bubbles indicating microcavitation bubbles. So here we have ultrasound only. This is the blood within the tubing right here. So if you follow this area here, now you add the laser, you see a ton of microbubbles forming within that area. You remove the ultrasound, and with the laser only, you're only getting rare microcavitation bubbles. So it's really this synchronized effect that's causing these microcavitation bubbles that then occludes the blood vessels via the photoacoustic effect. We modified our system for treating the retina and the choroid. This is a schematic of our system. And then we started treating, this is normal, healthy choroidal vessels in a New Zealand white rabbit. And you can see that after the treatment initially, similar to PDT, it's not like you get this immediate effect. You actually see the effect in the loss of the blood vessels typically within the first week or so. And you get this long-term 4-week sustained non-perfusion within that treatment area. This is using indocyanine green angiography, ICGA, showing that you actually have non-perfusion within that region of treatment that's indicated with the red circle. This is in several rabbits. We can change the size and shape and so forth, but you see that a month afterwards, you get this sustained long-term non-perfusion. We did several controls with laser and ultrasound only, and you see absolutely no effect because the laser fluence that we're using actually does not cause permanent damage or changes that we can visualize. It's only by the synchronized laser and ultrasound that you're actually seeing an effect. This is a model of retinal neovascularization or diabetic retinopathy, where we inject in intravitreally VEGF, vascular endothelial growth factor. We see a robust development of angiogenesis and vascular perfusion. We treat the area and we see a significant reduction within a day of the perfusion within that area of treatment. We could treat several animals and demonstrate actually consistently that within the area of treatment with PUT, you can actually get a reduction in the perfusion. This is a more sustained model of retinal neovascularization using DL-AAA that gets us long-term sustained angiogenesis as opposed to that VEGF model. This is in a pigmented animal, and you can actually, again, see that you reduce the perfusion within that red circle of treatment zone. You can see here with the green circles indicating our PUT treatment zone. Initially, you have a lot of RNV within that area, and you get sustained long-term reduction in that RNV within the green circle of treatment area. This is in Dutch-belted pigmented animals, where you can actually see the same result with a reduction in the RNV with the PUT treatment. This is a quantification of that, where this is our fluorescent leakage area here. On the left is in New Zealand white rabbits. On the right is Dutch-belted pigmented animals. And so you can actually see a very significant reduction, even within a day after PUT treatment, that's sustained over the course of 6 weeks. you get a little bit more of a modest enhancement in the Dutch belted pigmented, but actually, as you follow it out further to 6 weeks, you get a significant reduction in that RNV area. We then moved on to choroidal neovascularization. We have a CNV model where we inject in Matrigel and VEGF in the subretinal space, and we get long-term sustained choroidal neovascularization, or CNV. We have our red circle here indicating our treatment area, and then we can monitor it over time. Again, seeing that you get non-perfusion within the area of treatment. We can do that in several animals and see this sustained long-term non-perfusion for a month afterwards in numerous animals. As controls, we actually see absolutely no effect on our CNV with just ultrasound or laser-only controls. Quantifying it after PUT treatment, we actually get a very sizable reduction in the red line here in terms of our relative leakage within the area of treatment. And you actually see that for laser and ultrasound only, we don't get any effect. Doing histology and immunohistochemistry, we find that our models can actually affect the normal retinal architecture, but we get no change at all after PUT treatment, and also demonstrating it in pigmented animals also. You can actually do photoacoustic guided PUT also using the photoacoustic signal that's generated by using some of your nanosecond lasers for photoacoustic. And by doing that, what you actually see is that when you get a shrinkage of the vessel, you get a reduction in your photoacoustic intensity. When you're just treating it, you get this kind of B where you just have noise. And then if you get any hemorrhages, you get a significant increase. So what you can do is look for that reduction. Once you get the reduction, you can actually stop your treatment. And by doing that, we can selectively kind of treat the areas without causing unwanted damage or hemorrhage. So in conclusion, PUT, or photomediated ultrasound therapy, can selectively treat vasculature without damaging surrounding tissue using this synchronized combined laser and ultrasound. It can reduce the energy that's required while increasing the safety window. You can actually selectively treat arteries versus veins. You don't require any exogenous dye or contrast agent, and you can treat pathologic vasculature, including CNV and RNV. So I'd like to thank all the members of my lab group. It's always a team effort with research. I'd like to thank our sources of funding, primarily the National Eye Institute and the Department of Defense. And thank you all very much for your attention, and I welcome any questions.
Great, thank you, Yannis. Do we have any questions or comments? We've got 5 minutes to discuss.
We have a raised hand.
Yes, if possible. First of all, I'd like to thank Yannis for this wonderful presentation. And I wonder about the duration of this treatment. I mean, when do you see a reperfusion of the vessel? And the second question is about the atrophy. In the long run, have you seen any cases showing atrophy at the level of the retinal epithelium? Thank you.
So that's a great question. So for the first one about the duration of the treatment, we followed it now out to at least 4 to 6 weeks. And we're seeing that for that 4 to 6 weeks, it's sustained in terms of the non-perfusion that we're seeing. We have started to follow some longer for out to 3 months. And in a limited number of animals, we're also finding that it's sustained. Some of the previous literature seems to indicate that after about 1 month, if you get sort of permanent non-perfusion and reduction in the vessels, it's typically sustained thereafter. So it's usually that reperfusion happens in the first month. So my guess is this is likely a long-term permanent change. But I would say I have very good evidence in numerous animals that we have sustained treatment for 4 to 6 weeks, in fewer animals for out to 3 months. For your second question, in terms of atrophy over it, certainly if you remove all of the vasculature, without vasculature, any sort of tissue will typically atrophy overlying it. So our goal for this treatment clinically, as we move from kind of these animal models into the clinic, is actually to remove the pathologic vasculature, such as the RNV or CNV or whatever we're targeting, without moving all of the vasculature. So as a result of that, my hope is that we will not get atrophy. We did not see in our animals actually that we got additional atrophy over what we get in our model creation. So actually, when you do subretinal injections in rabbits to create the CNV, you create some amount of atrophy, but we didn't see any additional atrophy. So my hope is that we'd be able to give the treatment, remove the pathologic vasculature without causing atrophy. But I don't yet have data showing that I can reliably and reproducibly do that. And we certainly are looking forward to that when we move towards clinical translation.
Thank you. Quick 2 comments. So one is, could you briefly explain why the laser potentiates the ultrasound? I mean, what about the laser effect makes the ultrasound work synergistically with it to get the micropulse? And secondly, I don't know if anybody else has any experience, I'll bet they do, just treating feeder vessels with conventional laser. On occasion over the years, I've been able to do that. And when I've done it successfully, I have seen large areas of atrophy develop in the distribution of the occluded choroidal vessel. So I think that's a real concern, but we'll have to wait and see. But Yannis, could you explain the mechanism of the synergy?
Yeah, absolutely, Jeff. So that's a great question. And it is an area that we're actively exploring right now with a National Eye Institute R01 grant. So what we kind of expect to be the synergy is that when you have laser or ultrasound only, again, we're using a relatively low fluence of both of them, such that you get these occasional microcavitation bubbles via the photoacoustic effect. When you apply them both synergistically, kind of our hypothesis is that your laser tends to be the thing that actually makes more of these microcavitation bubbles. And then when you have these and that forms via the photoacoustic effect. And then when you have micro bubbles, in essence, within the vessels, we actually know very well that ultrasound really potentiates and can get, in essence, absorbed by those microcavitation bubbles. And by doing that, can really potentiate the action. So we know that giving sort of as exogenous agents, systemic microbubbles, you can really focus and potentiate your ultrasound. So by doing that and by having it synergistic, you're kind of creating these microbubbles. The microbubbles, if you didn't give it synergistically, would very quickly decay and actually resolve. But by doing them at the same time, you very quickly actually, in essence, cause the growth of those microcavitation bubbles, which then kind of damages the vascular endothelial cells and causes vasoconstriction and occlusion of the vasculature. So that's our hypothesis. We have a good amount of data kind of supporting that, but we are still working to better kind of have further data on that as part of our grant.
So you think the laser is just heating the blood so that it lowers the threshold for microbubble formation, basically?
Correct. Yeah, the laser is getting absorbed primarily by hemoglobin within the blood. So you're picking a wavelength that'll get absorbed by hemoglobin, and that's how you can target oxygenated versus deoxygenated hemoglobin. And by doing that via the photoacoustic effect, you're getting the formation of microbubbles in essence.
Okay, great. Thanks.
And then we do have another race with David Kent, if you want to go ahead and ask your question, David.
Yeah, hi, can you hear me?
Yes.
Yeah, great. Thank you. Thank you, Yannis, for a great talk. I just have a couple of comments, and you've kind of touched on it already there. My big concern, say, for example, if your indication is choroidal neovascularization and age-related macular degeneration, that by directly targeting these blood vessels, you're already making a hypoxic situation more hypoxic. And in the presence of abnormal blood vessels, that's a very pro-fibrotic situation. And we know what fibrosis can do to the outer retina. And again, something similar in diabetic retinopathy, for example, or venous occlusive disease. If you're targeting, you can take out all those blood vessels. Again, my issue would be with atrophy, as Jeff has pointed out there. Have you any, excuse me, any comments on that?
Yeah, I think that's an excellent point, and I certainly share your concern. Clinically, I would not envision this being used as I kind of did on some of the animal models where we really remove all of the vessels within a treatment zone. Would I actually envision this as more like almost like a sculpting situation? I mean, similar to, for example, how we use photodynamic therapy to potentiate things like polypoidal and other things. To me, this is, I envision this very akin to how we use photodynamic therapy, except not requiring Visidyne and other IV infusions and so forth, and not carrying all those risks associated with it. So I would envision it more as a targeted treatment to selectively sculpt the vasculature that you want to remove. I certainly share your concern. You would not want to remove all the choroidal vasculature within a region. You certainly wouldn't want to probably remove all of even the CNV within a region, for the concern that this CNV is really forming because of the fact that there is this sort of ischemia and that you're concerned about creating atrophy. So I think of it more, rather than, as I kind of showed here, of a sledgehammer showing that we could remove blood vessels, but rather more as a sculpting to selectively remove ones that might be more prone to hemorrhage or polyps or other things, and thereby kind of reduce the risk that you're going to have subretinal hemorrhages and vision loss associated with that. Because I certainly agree that fibrosis is one of the main reasons why patients lose vision, typically from subretinal hemorrhage, for example. But I also share the concern that atrophy certainly is a major cause of vision loss too, for example, with many indications of CNV. And you would not want to cause that by basically removing all of the vasculature, particularly the choroidal vasculature and so forth. So It certainly is. I think removing all the vasculature would definitely be a major concern. I think clinically, as we move towards that, we'll need to kind of more use this as a sculpting, selective removal of vasculature, hopefully to kind of potentiate anti-VEGF or other treatments that we're giving to patients to reduce the number of and the frequency of injections rather than necessarily as monotherapy, for example.
Okay, great. That's really interesting. We'll look forward to how that develops. There could be some real applications for that. And thanks for the questions. And David, lovely to hear your voice. We're going to move on, and we're going to try to put up a clock so everybody can kind of help keep track of time so we don't get too far behind. So next is Dr. Ohkoshi and her associates with temperature increase and damage extent at the RPE compared to between continuous wave and micropulse. Dr. Ohkoshi? Although now all we can see is the clock.
She should still be able to share her screen alongside it.
Okay, all I've got is the clock. And I don't see Dr. Ohkoshi's talk. Maybe we better can the clock. Okay, there we go. Okay, Dr. Ohkoshi, I don't hear anything. Have you started or?
Can you hear?
I can now.
Okay, thank you. I'm sorry. Thank you for providing the opportunity to present at this meeting. I would like to thank Jeff who arranged this Zoom meeting. This study was conducted and collaborated with Dr. Brinkman and Dr. Mueller in Lübeck Research Group.
Erin, you may have to advance your slide there.
Yeah. This study was supported by Iridex company. Subthreshold laser photocoagulation has been used for various macular diseases and has been reported the efficacy of this non-damaging laser ablation. Since today, laser instruments equipped with subthreshold laser system has produced by many companies, and Micropulse laser and endpoint management with continuous wave laser are two major systems for applying subthreshold laser. Continuous wave laser is standard laser application system in which laser is applied continuously. The Micropulse system applies repetitive microsecond pulses, and Micropulse mode require large power in a single pass to provide the same energy as CW. Although Micropulse and CW is quite different modality, very few report has been issued to compare the tissue damage induced by laser ablation in the same average power and same total radiation time using these two systems. Purpose of this study is thus to assess the temperature rise in experimental model, determining the extent of RPE damage by CW and Micropulse laser irradiations with the same average power and the same total irradiation time using porcine RPE explants. Freshly enucleated porcine eyes was used for laser irradiation. The anterior part of the eye was resected. A round piece of tissue composed of the retina RP choroid sclera were extracted using trypan. Neurosensory retina is peeled off. After incubating the tissue for 24 hours, the laser irradiation was conducted. An IQ 577 laser system was used for this study. This laser system enables laser radiation in the CW mode as well as in the Micropulse mode. After applying the laser to porcine RPE, damage analysis was conducted by measuring dead cell area. This is an image of cell viability, cell viability assay. Green fluorescent shows live RP cells, while non-fluorescent, which is the black part, is indicated dead or no RPE cells. These three vertical lines shows CW, Micropulse 15%, Micropulse 5%. laser applied with the same duration, 20 or 200 milliseconds, same average power, 20 to 90 milliwatt for each mode. Therefore, each horizontal line indicates the same average power. We also measured temperature at the irradiated site. Temperature was measured with up to acoustic temperature measurement. This was reported by Brinkman. Primary endpoint is to compare the extent of RPE damages by CW and micropulse laser irradiations with the same average power and the same total irradiation time using porcine RPE explants. Temperature rise was evaluated at RPE irradiation site with optoacoustic technique during irradiation in each mode. This is the result of dead cell area after 200 millisecond irradiation with CW micropulse with 15%, micropulse with 5%. There are statistically no differences in the damage area with respect to average power among all modes up to 50 milliwatt. The size of dead cell area rose almost linearly. However, when it exceeded 50 milliwatt, the slope at micropulse 5% dropped. In this parameter, visible microbubble formation were occasionally observed through the slit lamp of thermoscope, which suggests concurrent thermomechanical RPE damage through microbubble formation, resulting from exceeding the vaporization temperature at the melanosome within a short time range. This graph shows the comparison of the achieved maximal temperature at the end of irradiation time, Tmax end, between CW and micropulse 5% mode for 200 millisecond and 20 millisecond irradiation, respectively, for different average power, including the probe power up to 30 milliwatt. These are no statistically significant difference between CW and micropulse 5% for the same irradiation time. This graph shows representative temperature values for a single laser spot over an irradiation time of 200 milliseconds measured in the CW mode and micropulse 5% mode with an average power of 25 milliwatt on the same RP specimen, respectively. Micropulse mode showed higher maximal temperature, Tmax, than CW, which may leading to the microbubble formation. In summary, there were statistically no differences in the damage area with respect to average power among all modes up to 50 milliwatt. However, when power exceeded 50 milliwatt, damage size was smaller at micropulse 5%. Microbubble were occasionally observed in the micropulse 5% when the average power exceeds 50 milliwatt, suggesting the concurrent thermomechanical RPE damage. As to the temperature, there was no significant difference between CW and micropulse 5% for the same irradiation time within lower average power scale up to 30 milliwatt. This slide shows image schema for temperature rise, CW yellow, micropulse 15% green, and micropulse 5% blue. Micropulse mode showed higher maximal temperature, Tmax, than CW. The reason why slope of the RP cell damage versus the laser power becomes smaller in this case can be explained by the fact that the microbubbles reflect parts of the laser light before reaching the melanosomes shielded by bubbles. Thus, overall absorption is reduced. What needs to be further elucidated is the difference in sublethal biological effect of different duty cycles and compared to CW. Even though the average temperature increase is the same, actual temperature lapse was shown to be different between CW and Micropulse in the measurement as well as in simulation. Whether and which kind of biological difference can be caused in the irradiated RP cell is still unclear. Micropulse induces high temperature fluctuation in one irradiation, which might differently stimulate not only intracellular temperature sensor, but also mechanical sensors at the cell plasma membrane, such as TRPV and PIEGO channels, causing the different calcium ion flux and biological responses during CW radiation. Although this issue is currently unanswered yet to date, it is a crucial one for further clarification of the role of CW and Micropulse in the treatment. CW at lower power can also be essentially applicable to achieve sublethal RP hypothermia. Sublethal RP thermal radiation is also possible with shorter duration CW radiation as well, such as 10 to 20 milliseconds as in endpoint management, and radiation with updacoustic temperature control that is currently under development. There's no differences in conclusion, there is no difference in the average temperature rise and damage extent at RP between CW and Micropulse mode at the same average power, regardless of duty cycle. These results suggest that for the same average power equivalent, the lower power CW mode can be used as safely as the Micropulse mode. If titration is conducted up to visible bound with Micropulse at lower duty cycle, special caution is required regarding the mechanical damage of tissues due to microbubble formation. Further studies will be necessary to clarify the differences of biological effect to RP between Micropulse and CW modes. This study was published in Life 2022. Thank you for the attention.
Thank you. Do you have any questions? We've got about 3 minutes. Okay. If not, I have a question. Can you leave that slide there?
Excuse me?
Can you put that slide back on showing the damage again? The one before. Yes. Yeah, thank you. What's interesting to me about this, and there's something missing here that I don't understand, is that this is very much at odds with clinical experience. It's not consistent at all. And so I'm wondering, when you say the same average power, there's something here that isn't comporting with clinical experience. Any mode of laser can increase the temperature to a certain point. Any mode of laser can damage the retinal pigment epithelium. But the idea that, anyway, anybody else want to chime in here? This is just very counter to actual experience on tens of thousands of patients. So can you explain why in practice, for instance, I just gave you in practice, I use exactly the same laser settings with a 5% duty cycle on every.
Oh, yes. And this is actually the experimental model.
Yeah.
And then the media was extracted, so laser is directly goes to the RPE without translating to the tissue. So this experimental model is different.
Let me finish my thought real quick. So I don't think that's an issue with me because I only use 810 and it has minimal absorption by anything but the melanin. Okay. So I don't think any pre-absorption or thing, but so I treat every eye with exactly the same laser parameters. I treat the fovea in every eye. I have never, ever seen any evidence of injury from that. And that's at least 50 or 60,000 treatments. Okay, with identical laser settings on every eye. We do electrophysiology, we do every kind of visual function. It only improves. If we were damaging the retina, as this suggests that we should be doing very likely damage to the retina, then that couldn't possibly be the case. And so
yeah, this is just experimental model that prove the damage level between CW micropulse 15%, micropulse 5%. So this is not unhuman, and we always use sub-threshold level so that we can see the damage in the RPE, but it's just like a kind of calculation of the damage. We tried the calculation of the damage and compare the CW micropulse 15% and 5%. So this is not clinical level.
Is there comments?
Yeah.
I beg your pardon. What is the spot size of this lasering?
I'm sorry.
Jeffrey, maybe the issue is that this is direct illumination of the RPE. So they did not lost any energy in fiber optic with reflection on mirrors, so on.
I don't think that's the issue. That might be the issue if it was visible, a wavelength that might be absorbed by media and so on. I don't think that's the issue here. So anyway, it's very difficult for me to understand because it's very much in conflict with vast amounts of human data. But we do need to move on unless someone can shed some very quick light on the subject, which I think is going to be difficult. But thank you very much, Dr. Ohkoshi. We really appreciate your contribution, your colleagues and their time and expertise, and love seeing lab work done on lasers, and you guys do an excellent job of that. So we're going to move on to Dr. Dr. Bianco for thermal laser photocoagulation and vasoproliferative tumor with exudative retinal detachment, a case report.
Hello to everyone. Good evening. Can you see my slides?
Yes.
Okay. Thank you to the organizers for this wonderful meeting and for the opportunity to participate. This is just a small case report, and I'll try to make it short for a further discussion later. So it's about a 76-year-old woman who is presenting with a 2 months history of deteriorating vision in his right eye. She has no significant past medical history. Her BCVA is 2200 in the right eye and 2025 in the left eye. And she has, on fundoscopy, she has exudative retinal detachment involving the fovea in the right eye. So we can see the fundus photograph. We see some hemorrhages and some pigmented lesion in the inferior temporal periphery. We zoom in and we perform an OCT scan over the lesion and over the fovea. We see that there is an exudative retinal detachment involving the fovea, as well as a small epiretinal membrane overlying the whole macula and inferior temporal periphery. Angiography demonstrates extensive leakage from the inferior temporal lesion as well as macular leakage. The left eye as well shows a pigmented temporal lesion, but in this case, there was no exudative retinal detachment. So the diagnosis of vasoproliferative tumor in both eyes was made, and the decision was to treat both eyes with thermal laser photocoagulation using 810 diode laser with the following settings, so 500 micron spots and 0.5 to 1 second of time. She underwent 4 sessions in the right eye and 2 sessions in the left eye, using both an indirect and direct approach over the lesion. And this is the 3 months of follow-up, where we can see that the lesion started to regress with some fibrosis overlying it, and the exudative retinal detachment resolved completely. And we can see also a reduction of the leakage on fluorescein angiography. And this is the OCT that demonstrates the complete resolution foveal detachment, and their vision improved to 2032. This is an OCT scan, wide field OCT scan that demonstrates that there is no exudative retinal detachment overlying the lesion, but there is a possibly worsened vitreal traction after the treatment. That possibly explains why the patient still shows some blood-retinal barrier breakdown. And this is the left eye that is still stable with some leakage, but no new hemorrhages or exudation. So retinal vasoproliferative tumors are usually distinguished between primary and secondary. Primary are idiopathic, while secondary ones are associated with other retinal diseases. They are similar because of the location is often inferotemporal, and they are located between the equator and ora serrata, and they have a similar prevalence of exudative retinal detachment, but are distinguished because secondary ones are always bilateral, the age of presentation is often younger, and the visual acuity is worse. Secondary vasoproliferative tumors are often associated with retinitis pigmentosa and all sorts of retinal diseases. And in our patient, no such ocular condition could be identified. So this is a very atypical case of vasoproliferative tumor with bilateral presentation. And several treatments are proposed in the literature, including cryotherapy, brachytherapy, and also pars plana vitrectomy and endolaser. A single cohort study, a smaller case series, reported about the outcomes of slit lamp laser photocoagulation with excellent results, I would say, and the resolution of macular edema and exudates in all patients, and improvement of BCVA, such in our patient. So in conclusion, this is an unusual case of bilateral primary vasoproliferative tumor of the fundus, treated with thermal laser photocoagulation that is an effective method for managing such lesion, even in the presence of exudative retinal detachment, and should be probably considered as a first-line treatment, while considering that the thermal effect of laser on the vitreous may worsen vitreous traction, pre-existing vitreous traction, and a membrane with further blood-retinal barrier breakdown. And I thank you all for the attention.
Great, thank you. Thank you, Dr. Bianco. Interesting case. Does anybody have any comments or questions? Well, if no one else does, I always have a comment.
I can jump in there, Jeff.
Okay, go ahead.
Yeah, no, I just, this, why isn't this just, I don't know, recurrent peripheral choroidal neovascularization that we can sometimes see? I just maybe struggle when you compare, say, what you've just shown there with the publications from Jerry and Carol Shields. Could this just be a big exudative peripheral CNV with a disciform lesion? And that's all really. I'm just looking at the differential or the other possibilities here, especially as it responded so well to the laser as well. That's all, but I enjoyed the case. Nice quirky case. Yes. They always excite me. Thank you.
Yes, this could be, of course, an option. Perhaps there is not really much pigmentation in the lesion, I don't know, but perhaps, of course, is a possibility to consider. And we compare just with the previous cases in the literature. Of course, it's very typical since it's bilateral and responds so well to the treatment. But thank you for the comment.
Yeah. Anybody else? No, I would just. The interesting thing about this is the diffuse nature of it, that it's not focal, and it's very kind of white, and the leakage is very broad. And so I think David may have a point but I think it's an interesting topic. I show a case in my book of a retinal angiomatous lesion very near the macula that was very highly elevated and had a serous detachment around it and cystoid macular edema that I treated with SDM Micropulse, no retinal damage. And I treated it with Micropulse just because that's what I do. And I really had no expectation that was going to probably do much, but I figured it wouldn't hurt. And I was really shocked that it dried that lesion up and it never leaked again. And it's been now, I don't know, 7 or 8 years. And so I just always promoting, you know, give less a try. It's always interesting to give the non-damaging treatment a try. Although if this was indeed a choroidal neovascularization, that would not have been sufficient, that's for sure. But very interesting case. Any other questions or comments?
Thank you. Thank you.
Thank you very much. I think we're going to just move ahead with Maurizio and his associates' presentation of photobiomodulation for intermediate AMD in a real-world setting. Okay, Maurizio.
Thank you, Jeff, for organizing this excellent meeting, and thank you also to your staff because they are going to help me with the presentation. May I have the first slide, please?
Yes, one moment here.
Thank you, Erin. So what's the definition of photobiomodulation? The next one, please. PBM can be defined as a form of laser therapy based on non-ionizing and non-thermal laser approach, stimulating photophysical and photochemical events. We can go on, thanks. In order to produce a regulation of the selectivity. The next one, please. The target of PBM is at the mitochondrial level, and more specifically to the cytochrome C oxidase. Go on. Thank you. The next one, please. So the activation of the cytochrome C oxidase results in several biological events, including improvement in the blood flow, activation, reduction of the oxidative stress, reduction of inflammation. And the wavelengths are in the near infrared, and generally PBM is delivered using the Valleda system. May I have the next one? The first study demonstrating a clinical effect of PBM in AMD was the LightSight 1 study. The next one, please. Here you can see the design of the study, just 30 patients with the 1-to-1 randomization, 12-month follow-up. The next one. And the patients were affected by stage 3 ARES classification. The next one. And the results were very interesting because PBM led to a visual acuity improvement. Next one. Contrast sensitivity improvement. Next one. And also a reduction of the bruising volume. This kind of reduction was registered in about 70% of cases with respect to 100% of treated patients showing an increase in the drusen volume. Next one. After LightSight 1, another 2 trials, LightSight 2 and LightSight 3, confirmed this kind of results with a visual acuity improvement of about 5 letters, CNT reduction, partial reabsorption of drusen, and potentially a good effect on atrophy. The next one. In addition, another study run in France with a 6-month follow-up confirmed the slight visual acuity improvement with the partial reabsorption of drusen. Next one. But point is, what's the real world application? I mean, are the visual acuity improvement results repeatable? And do the patient notice this kind of improvement? And what happens in the long run? Next one. So we decided to design a study recruiting patients with AMD and treated with PBM over a 12-month follow-up in order to understand exactly what happens in the real clinical practice. And secondary outcomes included CNT, drusen volume, constant sensitivity, and most of all, CNV onset. Next one. So, consecutive patient in a private center, which is related to the activity of our university center, and photobiomodulation was performed with 3 applications per week for 3 consecutive weeks, and it was repeated after 6 months, follow-up 12 months. Next one. Here you can see an example of one of our patients. As you can see, this is quite a typical case because there's an epiretinal membrane, so it would be excluded in a trial. As you can see, there's a reduction of the amount of drusen and reduction also in CMT. Next one, please. And now our results, 44i of 22 patients, mean age 68. All the patients completed the treatment, and 3 patients with epiretinal membrane, no patient with geographic atrophy at baseline. Next one. Visual acuity improved as expected by 5 letters. Next one. CNT reduced. Next one. Drusen volume was stable. Next one. We registered an improvement in constant sensitivity. Next one. So overall, we had a slight visual acuity improvement, just 1 line, with a reduction of CMT, but no reduction in the drusen volume. Next one. The patients show good compliance to the treatment, even though this treatment is extremely boring. But the mean interval between first and second session was not 6 months as scheduled, but 7.3 months. The patient turned out to be satisfied by the treatment. No patient developed GA, but 2 patients unfortunately developed CMV. 1 patient after 3 months, and the other patient at 9 months. The 2 patients underwent anti-VEGF treatment, and at the end of the follow-up, they retain a good visual acuity 2025. Next one. So we can confirm that also in the real life, we can achieve a visual acuity improvement similar to that registered by the trials. Patients were satisfied with treatment, but we know nothing about the natural history because we had 2 patients out of 22 showing CMV, and now we can discuss together. Maybe photobiomodulation was performed too late, or it's unable to control the CMV onset. Next one. So promising approach with a slight visual acuity improvement, but we have no clear information about the natural history, and so we cannot say that this is the real solution for AMD. We need longer-term studies in order to understand exactly what happens. Thank you so much.
Thank you, Maurizio. That's a great study, really interesting topic. Everybody's interested and excited about it. It's got a lot of potential, probably. I don't know if anybody remembers, but we had the developer of this system speak at Light 5-6 years ago, talking about the early stages of this. Aaron, I don't know if people have their hands up, but I would really like David Kent, are you there? I'd love to hear your thoughts on this if you're...
David has just raised his hand. All right, David, you're good.
Yeah, no, look, it's fascinating, and as you've said there's very little we can kind of glean from this study. I'd like to know a little bit more about or understand more about the mechanism of action and whether there's any good kind of preclinical data there. You know, a kind of a shortish study like this, you know, a critic would argue that, oh, you're doing something that is actually causing the CNV, whereas a short study like this, you're not really going to see the development of geographic atrophy at this stage anyhow. But it is fascinating, and I haven't quite in my own head figured out exactly what's going on, but it is very, very kind of interesting stuff. And again, addressing the whole power of light. I wonder myself, and I've no data or support for this, about the whole energy crisis that we now know is going on in the RPE. You know, by energy crisis, I mean, you know, sick RPE have sick electron transport chains, and that whole concept of the energy crisis and age-related diseases, and whether by directly addressing the mitochondria like this, it may be, I don't know, tripping that, reducing the number of reactive oxygen species, because that's what fundamentals of disease are initially. Yeah, so it really is a provocative talk, and I really enjoyed it. So I guess I'm saying, I'd love to know more about the mechanism of action. Maybe you have thoughts on that yourself, and yeah, watch this space. Really enjoyed it. Thank you.
Oh,
And,
David, sorry, Ari. Thank you so much for your comments. Very, very well taken. To me, the most important, we are going up on with the follow-up. I mean, we try to prolong the follow-up in order to understand exactly what happens in the longer term. We have another case developing CMV and no case developing geographic atrophy up to now. To me, the most important finding of this small case series is the reduction of the CMT, whereas the drusen volume is still the same. So the three light-side trials provided controversial results regarding contrast sensitivity and also drusen volume reduction. So the number of the patient examined was not so huge. So there's a high variability among patients in stage 3, in RS stage 3. But I suspect that maybe the most important effect is at the level of the retinal epithelium with respect to the drusen volume.
Right.
and Stephen also had his hand up.
Yeah,
No,
very
I'm good now. Thank you.
Just to make a couple quick comments. One is that it's interesting, like you say, the thinning of the central macular thickness despite no change in drusen development. I'm going to talk about some OCT studies later, but one of the things we've seen when we really started looking at retinal thickness and all that in AMD is that retinal thickness, macular thickness, it continually declines, thins. So this thinning of CMT may just be a red herring. It may just be a normal physiologic thing that happens with time. It may have nothing to do with the treatment. And my conception of PBM is really that it's really, as David said, mainly working by increasing metabolic efficiency, metabolic activity. When patients ask me about it, I tell them that PBM is kind of like taking a Red Bull. You know, you get a big shot, a big bolt of energy and all this, but it's not the same as daily exercise. Okay. And what we're really looking for, and what I think we have the alternative is the daily exercise part. The Red Bull thing may have benefits, but the question is what's the long term? And the other thing I wanted to just say quickly back to David is, you know, you've got this sick RPE, and in a sense, if you use PBM to spike up the mitochondria and increase metabolic activity, absent other improvements in cell function, for instance, absent improvements in cell proteostasis and so on, might you actually be perversely stressing the cell and possibly causing long-term harm by causing it to kind of go into overdrive when it doesn't have the facility to handle that kind of activity? That's for David.
Well, I think that nobody has an answer, a clear explanation about this very new treatment involving a very limited number of patients at the end of the story, because a few hundred of patients were treated. So we need more time and more patients.
Sure. And if I could jump in there, just I often think about that, actually, that we intervene, and you mentioned the Red Bull there. I just think of, you're throwing the RPE cells up on the treadmill and you're speeding them up, you're getting them near the finishing line, but you are actually exhausting them, as you say. So maybe in the long term, we are accelerating their demise, but only a long-term study and is ever going to be able to answer that question for us. And what our, other than the development of atrophy, which we wouldn't want, what our biomarkers would be, and something like that would be quite a challenge. But I agree with you. I often think we stimulate cells sometimes without thinking of the kind of consequences. Thank you.
Other questions, comments?
Oh, we have one from Igor here.
Oh, go.
Yeah, Maurizio, very nice talk. So I would like to think about this new concept of senescent cells that actually came up in connection with CNV formation following the complement inhibition as part of geographic atrophy treatment. And the theory basically says that there are these, senescent cells that are going to die, and the natural immunity would clear it, and by inhibiting it, we are actually prolonging their presence, and they continue to produce VEGF, and that can be one of the reasons of formation of CNV. And I was thinking whether something like that, some identical process can be happening, with these laser treatments that is sort of like helping on one hand, but then you are keeping a pool of tissue or cells that actually can be detrimental. So this is just the proposition.
Well, Igor, thank you for your kind comment. Obviously, I've no answer. Just one hint. I discussed about CNV development after PBM with other friends, and we agree that at least in the short term, people developing CNV after PBM fare well. So they require less injection, and visual acuity is generally high. So this can be something that should be obviously deepened over longer term follow-up and on the basis of larger number of patients, but maybe some kind of beneficial effect could be seen also in those cases developing CNV.
Yeah, but it's still CNV, it may be different, it may be milder. We still need to study the CNV that we find in geographic atrophy simultaneously. So they may just be a different CNV, as we know it.
You may be right. You may be right. Thank you.
And Stephen had his hand up, and then David.
Yeah. Maurizio, thank you very much. An excellent discussion. I have one question and one comment. The first question is, I tried to find out from the Valeda system that uses LEDs, how you control the cone of intensity that's produced in the retina, where it's very hot in the center and diffuse more towards the periphery, as opposed to the laser or laser scanning systems where it's more uniform. Can you just comment on how this is controlled in the system?
That's a very wonderful question. To be honest, I cannot tell you anything. I have no idea about that, but you are perfectly right.
Okay, I try to find out as well. Okay, number two. Number two, it's just my comment is we've used so much chart measures of vision, whether it's best corrected visual acuity, that is, remember, it's high contrast photopic visual acuity, and we now know that the rods are much more earlier affected. So to develop non-invasive, I mean, we have to, come on, gang, we have to develop methods that are less invasive and more tolerated by patients than the intraocular injections. All right. So for earlier lesions such as this, we need to use other methods of functional measure. What do I mean by this? Well, come on, macular diseases are multifocal and most often begin extrafoveal, and they progress until they involve the fovea. So what the patient is doing with charts is moving their eye around the chart to find the best function. And so, come on, I'm prejudiced because I've developed the first resolution visual field that measures your ability to see Landolt Cs in the foci around the central macula. And we can do this at contrasts and luminances that are mimicking real-world mesopic, etc. functions. All right, so we need to know where the lesions are beginning earlier in the stage and what the functions are so that we can begin these non-invasive treatments much earlier. That's just my comment. Everybody knows I'm prejudiced, but I think that's where we have to go. Thank you.
Thanks, Stephen. I've never heard you say those things before. Appreciate it.
Thanks. Okay.
Any more comments?
David had his hand up as well.
Yeah, thank you. And Stephen, I just quickly say you need to speak to the CAM group to tell them all about your device, because they are torturing themselves about coming up with endpoints specifically for the treatment of intermediate AMD, and your device addresses that perfectly. So you really need to get onto the great and the good, as they would have themselves believe. Just one or two comments about, I can't think of a better treatment for immunosenescence or indeed stromal senescence than SDM. I just think it's such a neat concept of recruiting an immune response, activating in situ microglial cells, so that, you know, they can, because the problem with immunosenescence, the cells are there, they're senescent, but the immune system is just failing. You know, their MER-TK apparatus is failing just to go in and take these senescent cells out of the equation. So I think SDM is perfect for that. And just a quick comment on CNV development for the complement inhibitors. I think it's a big problem. I would say that, you know, to me, it highlights the importance of the innate immune system in protecting us from the development of choroidal neovascularization, and then going in and actually tampering with their innate immune system. This is what we're going to get. And yeah, so I just wanted to make those points. But finally, just in relation to the presentation we've just heard, I guess if we're developing CNV, we're picking it up a little bit earlier, and maybe that's why they're doing better in the long term as well. Thank you.
Yeah, and I agree with everything you've said. We have to start earlier. I'm trying to develop a new imaging device, multispectral, that will define just exactly those inflammatory and early oxidative changes.
We need it, Stephen. Yeah, absolutely.
Yeah, absolutely.
Great. David, thanks for those comments. Your check is I appreciate that. And Maurizio, I have it. One of the things about PBM, let's say this thing works fantastic. Long term turns out to be great. It's the new gold standard for all this. One of the problems I see with it is, as you kind of alluded to, is that it's pretty time consuming, and it's done in the office. How could you imagine treating all of your dry AMD patients with PBM in the office without having to rent another 5,000 square feet and getting 20 machines that work day and night? What do you think about the practical implementation of this? I can't see it being done except as a home device, which then would probably not be used eventually.
Well, I agree. This is very boring treatment for all our patient. I mean, time consuming, and the patient are old, so they need to move to reach a center. I believe that if this kind of treatment really works, well, I believe that would be easier to send the instrument to the patient, so they can conclude their treatment session. Home. Yeah. Sorry, there's some kind of overlapping of voices.
Yeah, Aaron, we're getting echo now for some reason. So this has been, Maurizio, this has been a really great paper. We've extended the discussion. We took Dr. Gowecki's time. But we're going to move on now. And a lot of what we talked about will kind of cover the next talk as well by Dr. Antropoli. And Dr. Antropoli, if you're ready, we'd love to hear your presentation.
Yes, thanks for the introduction. Do you see my slides?
Yes.
Perfectly. So as you just said, the case I'm going to present links very well to the discussion you just had. And so let's move on. So as introduced by Professor Battaglia, photobiomodulation is a promising approach for intermediate AMD. The details regarding its functioning has been well explained by Professor Battaglia and involve the combination of different wavelengths to target the mitochondrial metabolism. And it has been proved effective in improving visual acuity, contrast sensitivity, and also reducing the drusen burden. So the LightSight trials, just a brief overview. We had in 2016 the LightSight 1, that was a single center study that showed an improvement in both BCVA score and also central drusen volume. The LightSight 2 confirmed these results both in terms of BCVA, drusen volume, and also in terms of safety, although it was partially burdened by the influence of the COVID-19 pandemics. Luckily, we had also the LightSight 3 trial, the results of which it just ended, and the results of which are already out concerning the in itinerary 13 months results. And besides confirming the previous LightSight 1 and 2 trials, we also know now that there is a lower incidence of geographic atrophy in patients treated at PBM at 13 months. So now with this in mind, we can move to our case. We have a 63-year-old woman with intermediate AMD in the right eye. Past medical history was negative, and past ocular history was only significant for cataract surgery, uncomplicated. The baseline visual acuity was 20 out of 25 Snellen, and on OCT, she came because of a drusenoid PED. So the patient underwent 3 sessions per week for 3 weeks consecutively. And at the end of the treatment, so at week 3, the visual acuity remained stable. The patient was happy with the treatment, although at week 5, so 2 weeks after the last treatment session, BCVA suddenly dropped to 20/50. And on OCT, we can see that there is now a complete collapse of the PED with complete RP and outer retinal atrophy. So before trying to understand why this happened, let's look at the precursor lesions that are known to precede drusen collapse in the natural history of AMD. One of the most cited ones is the nascent GA, which is defined as the subsidence of the inner nuclear layer and the outer plexiform layer onto the drusen peak. And these have been reported to precede drusen-related atrophy up to 5 months. Then we have the persistent hypertransmission defects, incomplete RP and outer retinal atrophy, although also called iRORA, and then the pigment migration. So back to our case, we can see that there is no nascent GA, although we can see that there is already pigment migration. There is some iRORA and also a faint initial posterior hypertransmission. Although the timing is not consistent with this natural history, because instead of happening in 5 months, the drusen collapse happened in just a span of 5 weeks, which is much earlier, almost an acute complication. We searched, therefore, the literature, trying to review if there were similar cases, and we found a clinical case report of a drusenoid PED collapsing, developing a rupture after 6 months, but the imaging findings were much different from our patient. And in LightSight 3 trials, as you were also discussing before, they reported possibly increased risk of MNV, and also that at 24 months, still 5% of the patients that are treated with PBM develop GA, although we don't know the time span of occurrence of this geographic atrophy. So we can not know if some of them were acute cases of drusenoid atrophy. So in conclusion, PBM may accelerate the natural history of PEDs that are already predisposed because they already show the risk factors for atrophy. And therefore, we recommend caution in proposing PBM treatment to patients that already show drusenoid PEDs that are imminently going to develop GA. And future research, in speaking of this, should investigate what are the baseline OCT characteristics that define if a PED is going to resolve or to collapse and therefore develop atrophy. Thank you for your attention.
Great, thank you. Thank you, Alessio. Any comments that we haven't covered in the previous talk?
No hands raised yet.
I would just make an observation. It's interesting that I'm just reflecting on my experience with SDM, and it just I have no data on this. I haven't had a chance to look at this. I don't know really how I would, but it seems to me that the development of PEDs is rare. Collapse seems to be less common, and there's something about the RPE function over these PEDs that it needs to retain some degree of function to maintain the PED, and at some point that function fails, and I think that's when the thing collapses. And so one of the if we're doing things to aid RPE function, then it should prolong the PEDs, which hopefully discourage them from developing in the first place, but also prolong them to decrease the risk of vision loss, because the kind of pretty much the almost 90% of them, at least, when they collapse, the vision drops considerably. I don't know if anybody has any thoughts on that, but this is an interesting case, and I appreciate it.
Yes, thank you for your comment. Indeed, speaking of the energetic crisis we were talking before, in my opinion, it is possible that after a certain threshold, so when there is already a big PED with some signs of impending atrophy developing, trying to accelerate their metabolism could be harmful rather than helpful, like in this case. So this is actually a possibility.
Okay, thank you very much. We're going to move on to Igor Kozak from Moorfields in the UAE and his early experience with pan-macular laser. Thank you.
Thank you, Jeff, and the organizer. It is great to be among friends and stimulate some of the discussion. So I'll be talking about my experience with pan-macular micropulse laser, even though it's not really early, but I'm happy to share the journey. It's not advancing for some reason.
Aaron, you want to help him move the slides forward?
Go ahead and click on the slide itself and see if that works for you.
Okay, it does. Thank you very much. So, my treatment evolution basically mirrored what the trends were in laser treatments. And initially, it was the belief that it's the leaking microaneurysm that's causing pathology and that you have to obliterate that one. And that, was done with focal threshold laser. And then, some ETDRS studies showed that you can actually apply grid and you can get rid of retinal edema, and so it doesn't have to be closure of microaneurysm, but you can get the same effect with perhaps less energy. And then, people started to use subthreshold treatment to, again, target these leaky spots and microaneurysms. And then, again, this trend of, subthreshold treatment, would be extended to diffuse grid treatments to the areas of retinal edema and, and in central serous macular edema, central clinically significant macular edema, and so on. And then this treatment has basically developed into panretinal subthreshold treatment as we knew more about, how things function. So basically, pan-macular covers the whole area of the posterior pole, and I like to follow the recommendation by actually our society, and these are parameters that you can use for different laser wavelengths when you perform these treatments. So basically, I have to say that I haven't photocoagulated the microaneurysm for about the last 7 years, and we were the ones to pioneer navigated laser navilas, where which actually depends and relies on closure of very precise closure of all microaneurysms, the active ones and even those ones that can convert to be active. And I still believe that eye tracking in retina is very important, but perhaps, you don't have to, you can do things differently. And so again, these are the parameters that I like to follow. And let me give you a few examples, and it is usually the recurrent or chronic patients of central serous chorioretinopathy that is a problem. It's not acute. And I had such a patient who had 5 Avastin injections in the US, and then that didn't really help. Then I used oral eplerenone, mineral corticoid inhibitor, and still the disease was not under control. And when I saw him, the vision was 20/32, and the patient was really symptomatic. And so we see some RP damage, chronic RP damage, and then this thin layer of subretinal fluid, which gives you an impression that it's been there for some time. Now, on fluorescein angiogram, you can see a multifocal CSR basically leaking from many sides, and some fluorescence pointing to the chronic RP changes. And the OCTA didn't reveal any obvious CNV. So basically my parameters, which I've been using for the last 3-4 years, are the following, and again, they pretty much reflect the light recommendations, 5% duty cycle, and usually the titrations goes around anywhere between 300 to 400 milliwatts, and I use area centralis lens. So this is the 1 month follow-up following the micropulse treatment, and the vision is much better, 20/25, and the patient is symptomatically better. There is some resolution of fluid nasal to the fovea, and then we see this patient 4 months following treatment, and his vision is almost 20/20, and he hasn't reached that in almost 3 years. So then we continue, and again, 5 months down the road, we see dry fovea and maintaining 20/20 vision. And then 7 months after the treatment, I repeated fluorescein angiogram. The fovea is still dry, and this is early and late phase of fluorescein of this patient. And this is comparison of pre-treatment fluorescein and post-treatment. And here we can see that post-treatment, we maybe have 2 active spots, compared to like 6 to 8 active spots before the treatment. So this was one of the striking cases. And then we have another one, central serous chorioretinopathy, recurrent one, which had all kinds of treatments, both systemic and photodynamic therapy, symptomatic in the right eye. And this is actually oral fluorescein angiogram. So it's not as bright because he refused injection fluorescein. But we see this diffuse subretinal fluid that is actually there. The choroid seems to be a little bit thicker. And then again, the same pretty much laser parameters, a little bit higher power on this one, pan-macular coverage, which basically covers all the posterior pole up to the arcades. I'm not treating through the fovea regularly. I did in some patients, but not in this one. And following the treatment, 1 month later, there is this dramatic improvement in vision and in anatomy. This stays, and again, this is another patient that hasn't been dry for about 2 years, and so with findings like that, you really think that there's got to be something that's happening. The choroid still may be a little bit thick, but there is no foveal fluid. Another case is a diabetic patient, uncontrolled diabetes, symptomatic left eye, and this is what we are seeing. So the vision is decreased to 20/40, and there is this foveal cyst, which, as you may recognize, can be resistant to treatment, and no matter what we use, again, the similar parameters. And this is following 2 months after treatment. The vision is a little bit better. From 20/40, the cyst is still there, but vision is significantly actually better. It's not only what we measure by ETDRS, it's what patients tell me. And then the vision continues to improve, and actually quality of vision continued to improve, and then the cyst is becoming smaller. The patient is happy. Another patient is this one that actually improved his vision in spite of some residual structural findings. And this is the point that I would like to highlight. If we use this treatment, if we rely on classical outcomes such as the presence or absence of fluid or ETDRS vision, sometimes we may be disappointed, and we may need to look into other parameters of visions that already have been mentioned. And many times when you ask in very detail, about the color vision, about contrast sensitivity, that's when most of my patients actually feel improvement. This is a very important case for me, because this is a pilot who flies for Etihad, and we are actually a center for aviation ophthalmology, so we are dealing a lot with this. And the pilot had to be grounded because of this finding, and this is actually not a fresh condition. He's had it for some time, but he's always met the aviation target, which is vision less than 6.9. Well, this time he's worse than that, and he had to be grounded. And there were several treatments that he underwent, and he was scheduled for photodynamic therapy. And instead of that, I gave him a subthreshold treatment, Micropulse treatment, and his vision improved dramatically to a point that he could fly again and stayed until I saw him, and he is flying now. So again, we need a longer follow-up, and things might change, but this was a very impressive case. And this is just a standard central serous that responds to Micropulse treatment. This is also another interesting patient. So this patient is a diabetic patient with poor vision, actually in both eyes, symptomatic. And this is post-treatment. This is 1 month post-treatment, I believe. And actually, on measuring ETDRS vision, he is seeing worse, but he's convincing me that he is seeing better. And he's pharmacist, so I try to tell him that it may be placebo, and he says, no, I indeed see better. And when I look at it carefully, in the right eye, we see these hard exudate that actually disappeared. And I'm thinking that that may be why, he is symptomatically seeing better. And the left eye actually has more of a perifoveal edema, but again, the hard exudate is smaller nasally, and the one on temporally is actually disappeared. So again, sometimes I'm finding this discrepancy between, the anatomy or ETDRS vision and what the patients tell me. So in summary, Micropulse pan-macular protocol in my hands have been applied to various retinovascular diseases, and I usually follow the recommendation by our group. I haven't had any adverse events or any damage yet, and I'm careful, and I'm following these patients very carefully. And again, morphologic and functional efficacy needs to be evaluated prospectively, and perhaps with different tools that we using at this moment. And with that, I would like to thank you for your attention.
Thank you, Igor. Let's see, Maurizio's got a question.
Well, thank you. Igor, I want to congratulate on the wonderful case you have presented, and also for introducing this concept. Sometimes the anatomical outcomes are not so good, but visual function tend to improve. So this is a special concept which can be related to PBM effect. Vision improves, but anatomically the situation looks the same.
Yeah, exactly. Thank you, Maurizio. And yeah, it's very important, especially people who are switching to Micropulse, not to be discouraged if we don't see the same effect, anatomic effect, as what we are seeing with anti-VEGFs, because it's a different philosophy. We should be looking at different things. And if we continue, or if we ask the right questions to the patients, we may start to understand better the potential of this therapy.
I think it's important to point out that the response to laser is physiologic. It's not pharmacologic. So it's going to, the last case you showed, Igor, the swelling had actually gotten worse, but it was pretty short term. So the laser hasn't really had a chance to do anything much at that point. Although it's interesting, it went away. And in our first OCT study of Micropulse back in, 2006, we didn't see significant improvements starting to come in till about 3 months. But then they continue, and you watch, and they slowly get better. So you have to adjust your expectations to the setting and what's going on. And this is really one of the most interesting things about it. Many times, and it's not just for diabetic macular edema too. Very, very frequently, if not the majority of the time, vision will improve out of proportion to the anatomic improvement. So that's good to know in diabetic macular edema. But there are a lot of diseases that we want to treat where there's not going to be any real anatomic change to be looking for. Certainly not in the short term. Dry AMD, for instance, let's say patients with subclinical ERMs that are symptomatic but not bad enough for surgery. There are many, many applications where you may not see a lot of anatomic change. What you're really trying to do is just improve their visual acuity. And that is where pan-macular SDM is extremely useful, because it just makes the retina function better no matter what's going on. And many times that will result in improvement in vision, which is really all we're really concerned about.
Yeah, exactly. And I know Stephen has a comment,
Yeah, just very quickly, in that pharmacist, those exudates that decreased, I think improved his reading in the periaxial vision because of the fixational changes that we have to do with reading that are not necessarily reflected by chart visual acuity. But I was also looking at some of the photoreceptor, and we pay more attention in the diabetic, as Jeff was saying, with the interretinal edema and stuff. And we know that this separates the neurons in terms of their connections, but we just have to be much better in our AI interpretation of these images to really understand what's going on with the functional vision. And, Jeff, Maurizio, you're all correct. Igor, you're all correct.
All right, any more comments or questions?
David has
David.
Yeah, no, I was just going to come in there. Yeah, I love that presentation. And again, I just want to really stress that, you know, the morphological effects, you can't stress that enough about how delayed they can be. And even though I suspect the biochemical effects, if you want to call them that, of laser are present within hours, if you know, and even a few days, even though they may persist. And from that point, it would be lovely to really support the use of laser, especially when it comes to selling it to the whole movement out there that is intravitreal injections, that if we could get something like aqueous humor to do analysis. Now, we can argue that aqueous humor is a supernatant of a supernatant, but it would be lovely to document the biochemical changes in aqueous humor biomarkers that hopefully reflect the vitreous and in turn reflects the retina, so that we can kind of give this more, I guess, clarity and objective confirmation of what we see with laser therapy. So I'm just kind of, if we could kind of move the discussion onto maybe the acquisition of aqueous humor to back up what we're saying, it'd be a great step forward in support of laser.
But, you know, Medina's done some work on aqueous proteomics and so on, and it supports all of that. But I agree, yeah.
Yeah, and I'm trying on my multispectral imaging to do exactly that, to look for the biochemical endpoints in the retinal lesions on imaging, but we're still quite a distance away.
Okay, thank you. I'm up next. I'm going to combine my two papers here because they're very similar general topic, and I'll try to go quick because I think discussion is going to be interesting here and get everybody's opinions. Can you guys see my? Probably can't. Let me see. Share screen. Share. Okay. Can you see my screen?
Yep, you're good.
Okay, great.
Yes.
Okay, so the first one is improve visual fields by standardized automated perimetry following panmacular laser for open angle glaucoma and other optic neuropathies. And there we go. Financial disclosures, we're going to get rich off this. So, you know what SDM is. We don't need to go over that. About 5 years ago, I published a study, and this was in a book that we were promised would be on PubMed, but never got there. And we had 88 eyes of 48 patients where we did electrophysiology and mesopic visual function testing using Stevens resolution perimetry and so on. And so we did panmacular laser on patients with open angle glaucoma accompanying in field loss, typical glaucoma patients. And we found that that panmacular laser significantly improved visual acuity on the chart, VEP amplitudes very significantly, PERG amplitudes as a measure of ganglion cell function, and mesopic visual acuity tremendously. And this was the first report of any treatment of any kind ever improving the VEP in any setting. So that was pretty remarkable. And so what this indicates is that in open angle glaucoma, there is an essential retinopathy. And we call it the retinopathy of open angle glaucoma, or ROGUE, because it sounds cool. It's a nice acronym. And so open angle glaucoma as a neurodegeneration is really another chronic progressive retinopathy that is associated with elevated intraocular pressures, and they work together to lead to blindness. So in the current study, I've done conventional perimetry on patients with before and after treatment over the years, but I've never really done it systematically, and usually just done it to show the patients the effects of treatment. And so I just wanted to go back and look at all the patients that we had standardized automated perimetry on who would have treatment. These patients had perimetry the day of treatment and usually within a week to 3 weeks after. Some of the patients were treated bilaterally before retesting. Others only had the worst eye treated before the retest. We treat the worst eye, they come back for the second eye. And when they come back for the second eye, before we did that, we test to see what happened to the first eye. And that way we kind of use the untreated fellow eye as a control. We use Humphrey visual field analyzers and Octopus, 10-2s and 24-2s. We always use the same machine and the same protocol for before and after testing so we could compare them. And we looked at the median deviation, mean deviation, mean sensitivity, and pattern standard deviation. These are the digital measures of perimetry. So we had 54 eyes, 28 patients. 47 of the eyes had open angle glaucoma. 6 were optic atrophy after AION, and 1 patient with optic atrophy from multiple sclerosis. 36, 36 eyes treated bilateral, or 36 treated eyes, 14 bilaterally, 22 unilaterally, and we had 19 controls. I apologize for the small screen here, but I've tried to highlight the main results. So if we look at all treated eyes, there was an average of, in the mean deviation, improvement of 3.65 and in the sensitivity improvement of 3.45. In the unilaterally treated eyes, almost identical improvements. And the controls, they improved as well, but not nearly as much. Now, I had never done much perimetry on patients. I'm as a retina guy, so I've had to kind of learn as I go and all that. But these are pretty remarkable improvements by degree. The p-values here, as far as these improvements, are pretty impressive. 7 times 10 to the 6th, 1 times 10 to the 4th. And interestingly, untreated eyes improved significantly as well, although quite a bit less than the treated eyes. And these are just some examples of that. Here's a before and an after. This is a Humphrey that's been modified to give a false color map so the patients can understand the results better, and brighter is better. Here's a patient with multiple sclerosis. This is a dentist with multiple sclerosis who had to stop practicing due to visual loss. And the upper left is before, bottom left is after, and she had very symptomatically improved vision after treatment. This is a really interesting one. This is a guy whose hand motions in his right eye. This is his left eye. He had been 20/80 for 8 years after AION. And so we see his Humphrey after treatment. He improved to I think 20/60 at this point. But I've been treating him now for about a year and a half. He is now 20/30 in this eye. So he has steadily improved 20/60, 20/50, 20/40, and now he's been maintained at 20/30 with optic atrophy from AION for quite some time. So basically, we see that SDM, pan-macular SDM improves all measures of retinal and visual functions and all the indications that have been tested. These improvements represent reversal of disease progression. And vision protection therapy is what we call this regular periodic treatment to maintain the benefits. People want to know what we're doing. We say we're doing vision protection therapy. It achieves marked disease reversals and visual loss reductions in AMD and DR. We'll talk about that more later. And we expect long-term effects for open angle glaucoma should be similar. And we can also improve visual function in VA and static optic atrophy as well. You know, there's a difference between glaucoma and optic atrophy from like AON. Glaucoma progresses, optic atrophy after AON tends not to, but both can be improved, okay? So I'm just going to go tearing on to the next talk here because I think we can discuss them both. Let's see, is this it? No. So we've just kind of shown how you can get significant visual field improvements in glaucoma and optic atrophy. So the question is, well, why? Okay. So this study is called Progressive Thickening of Retinal Nerve Fiber Layer and Ganglion Cell Complex Layers following SDM Vision Protection Therapy. That means this is ongoing treatment. The previous study was just one episode of treatment where we showed before and after field improvements. This is looking at ongoing long-term treatment in patients with open angle glaucoma. And it seems to suggest that we're actually eliciting neural regeneration in the retina with this approach. And once again, we're going to get very rich from this. So all optic nerve and visual indices tend to worsen in glaucoma despite IOP control. This has long been recognized to suggest there's an independent optic neuropathy in glaucoma that's independent of IOP. And that the only way to address this is actually address the optic neuropathy. So far, SDM has been the only clinically effective neuroprotective treatment, which means it's showing improvements in retinal function in all applications by electrophysiology and by objective testing and by subjective testing, visual function testing in all applications. So just terminology. So neuroenhancement means that we're improving neural function. Neural regeneration obviously means that we're somehow stimulating development of new neurocytes or axons or neural elements. Whereas neuroprotection really, we talk about neuroprotection, but neuroprotection really describes the long-term effect of enhancement and regeneration. That if you can enhance function and maintain it and possibly cause neuroregeneration, then you can achieve neuroprotection by preventing or slowing neurodegeneration. So retinal nerve fiber layer and ganglion cell complex layer thicknesses are common OCT measures. The ganglion cell layer itself is really too thin to get accurate measures on. So you've got to, the ganglion cell complex, which includes the NFL and the other layers, it's really about half of the inner retinal thickness is a preferred measure. Many OCTs now will calculate long-term layer thickness trends. In a recent study from UCLA, as I was thinking about this, I got my attention. They said that they concluded that the ganglion cell complex layer trend is the best measure of glaucoma progression, and that improvements in any of the nerve fiber layer or glaucoma or ganglion cell complex trends are very rare, and that they're so rare as to be statistical noise, because once again, glaucoma patients only get worse, they don't get better. Okay, however, over the years, just by accident, I've noticed that patients who have been getting SDM show increases in retinal nerve fiber layer thickness. And I haven't been quite sure what to make of that. I've asked glaucoma specialists, they can't tell me. They basically don't answer my question. But the question is that unusual? And is it associated with treatment? So what we did here, and this kind of goes over those concepts again, that SDM is neuroprotective, and by keeping up the treatment with vision protection therapy, we can hopefully reduce long-term visual loss. So once again, this is that study we published 5 years ago showing electrophysiologic and visual improvements in glaucoma that tell us that there's a retinopathy in glaucoma. And ROGUE is an otherwise undetectable and reversible retinal hyponeurotropism of RPE origin in open angle glaucoma that's responsive to SDM and the reset effect. And we know this because this is what we see when we treat eyes with a glaucoma and we treat the RPE. And those are the responses. So why treat the macula in glaucoma? Well, the origin of ROGUE, this hyponeurotropism, or it could even be a toxicity, is in the RPE. The macula has the most dense RPE, so you get the biggest bang for the buck in the macula. And virtually all the nerve fiber layers that make up the optic nerve come from the macula. So if you're going to affect the optic nerve, you need to treat the macula. So we looked at patients with and without glaucoma, or with and without vision protection therapy who had glaucoma. We excluded all the usual things, including poor testing and other factors. They had to have glaucoma and at least 4 OCT scans with good measures and trends of nerve fiber layer and ganglion cell complex layer. Once again, I apologize for the small table here, but basically had about the same number of patients, same age, basically same visual acuity, same pressures, and follow-up was about 2 years for both groups. This is an example of what we're looking at. So I use a Topcon Maestro OCT, which I would recommend to anybody. It's an incredibly good unit, useful. It's robotic, it's idiot-proof, and it gives you an amazing analysis. And so the top left shows nerve fiber layer trends over time. In this patient, I think it's about almost a 4-year period. And you can see how they're positive. They're getting better, they're getting thicker. And in the same patient, the ganglion cell layer thickness is improving. This is not supposed to happen. So here's the results of our study. And on the left-hand side, we see just the incidence of positive versus negative trends, okay? And so we see that for the ganglion cell layer, the majority still worsen, but the treated patients, it's almost a 50-50 split, whereas untreated, it's predominantly worsening rather than improvement. For the nerve fiber layer, once again, untreated very rarely improve, show positive trends, whereas treated patients, the majority show improving nerve fiber layer trends, which is just dramatically different than one would expect. When we actually look at the thicknesses of these layers, we see that treatment markedly reduces the progressive loss of ganglion cell layer thickness. And for the nerve fiber layer, it actually flips the progression to a positive average progression for all these eyes rather than negative. So the results are fairly dramatic. So in conclusion, SDM directly treats the retinopathy of open angle glaucoma by improving every measurable function, both objective and subjective. In this study, we show that it also improves nerve fiber layer and the ganglion cell thickness trends in OAG. This suggests VPT-induced neurodegeneration, and we can discuss why that is. Pressure control is insufficient to prevent vision loss in open angle glaucoma. That's well established. And so we also have to address the optic neuropathy, and that's what SDM does. So I hope I haven't gone too long there, and open it up for any questions.
Jeff, this is amazing. What are these patients on glaucoma treatment? I didn't catch it.
Oh yeah, these are all, in fact, all these patients were being treated. They're all actually being treated by the same glaucoma specialist. I have a glaucoma specialist a block away from me, and I treat a lot of his patients. And so he's actually, the same guy is actually treating all these patients. So it's not a difference in treatment. He's treating them all the same way. A lot of these patients were initially treated because they were referred for macular degeneration, and they had mild macular degeneration. And so I went back, and this is how we did that first study 5 years ago, and that I had a lot of patients with macular degeneration and AMD, and I wanted to see, well, gee, what's going on with the glaucoma in these patients? And very interestingly, in that paper 5 years ago, what we see is that the electrophysiologic signature of improvement is different for AMD and glaucoma. In AMD, the thing that improves very significantly are the signal latencies. And this is usually what you would expect. The signal latency improves. Signals are going faster. It's more efficient. Okay. Not in glaucoma. The signal latencies improve, but the thing that really improves in glaucoma in the VEP and the PERG are the signal amplitudes, and they improve quite a bit. So if you've got a patient with glaucoma and AMD, the glaucoma response with improved amplitudes actually outweighs the AMD response electrophysiologically, and what you see is improved amplitudes. So these are very significant effects in patients with glaucoma, but they're all treated and all actually treated by the same glaucoma specialist.
Steve, yeah, tremendous, Jeff. My question is, what was the name of the OCT that you're most enchanted with? I've been very disenchanted with OCTs. Yeah. I'm trying to develop a better OCT angio algorithms for analysis. But what give me the name of the one
TopCon. It's a TopCon Maestro 2. The beauty of this thing is a robot. Okay. If you have a clinical practice, your big nightmare is if your tech who does the OCTs and all that, if they quit or get pregnant or whatever, you're in big trouble until you train somebody else. This thing is a robot. It literally, you press a button and it does everything. And so you no longer need a trained employee to do your OCTs and so on. And it takes fundus photos as well. It's a fabulous machine. I would recommend it to anybody. Okay. It's very quick. Okay.
Thanks.
Any other questions?
Yeah, yes, if fascinating application of laser treatment, and I have to confess that I have no experience with this kind of application, and I wonder in terms of frequency, how often did you register an improvement in visual field, in nerve fiber layer, and also ganglion cell complex? How often?
Well, how often do you notice the visual field? In visual fields, we see the average improvement, once again, was about 3.6 decibels, okay? That is a huge improvement. Glaucoma people say that once you get a change of about 2 decibels, it's pretty solid that there's been a significant change. And so we're causing improvements that are nearly twice that, okay? And we see it in at least 90% of the treated eyes. Okay, it's very common. It is such a sure thing that when I have a patient with glaucoma and field loss, the reason I do this test is so I can show them what it's doing. And that helps them to appreciate the value of the treatment, so they'll be willing to keep it up. And so I'm not going to do that if I think it's not going to show any improvement, because then it's going to make me look stupid, right? So it shows improvement at least 90% of the time. I can count on it. And so it's very frequently. As far as the nerve fiber layer and ganglion cell layer improvements, in nerve fiber layer improvements where we see improving trends going up, not down, it's about 75% of the eyes. Okay, it's the majority. For the ganglion cell layer improvements, it's about 40% of the eyes. Now, one of the most interesting things is why nerve fiber layer more than ganglion cell? That's one thing. And the other is how do we know this is neural regeneration? But it's the majority of cases. These are not subtle effects. That's why the p-values are 0.00000, whatever. Okay, very, very robust effects.
Thank you. And how often do you believe the retreatment is necessary?
I treat these patients every 3 months. And the reason is I started treating them mainly who had conjunction with AMD, and that's kind of what we do there. I've done, for instance, PERGs and Stevens resolution perimetry on thousands of patients over the years. I don't do it much anymore, but in the past. And the treatment effects seem to hold very well for about 4 months, and then they start to decline. And by about 6 to 9 months, they're back to baseline. And so I just split the difference and go about every 3 months. And that's how we get these results. I'll also tell you that I've had several patients where many times they'll come in and at their next appointment, say 3 months later, and say, I could tell my scotoma was starting to come back last week or a week ago. Or I had one patient after about 6 weeks saying that scotoma was returning. And they can see their scotomas go away or regress after you treat them. And you repeat the fields, and sure enough, they worsen again. And so the effects are temporary. They last around 3 months or so. And that's why you need to continue repeating the treatment to maintain the effects. One time is not going to do it. I tell patients it's like taking insulin. You don't take it once and you're no longer a diabetic. You got to keep doing it. And that's where we get these results. So in the visual field study I just showed you, that's really a one-time before and after. But the nerve fiber layer OCT study here, this is long-term. And we can see that long-term, we're getting actual anatomic reversals of disease progression in these glaucoma patients.
Igor has a hand up as well.
Yeah, thank you very much. So once, Jeff, this is reproduced by others, I think it's revolutionary, It may already be in your hands, but and thank you very much for teaching us about that. 2 questions. One, to be a devil's advocate, you also showed that in controls there was an improvement, not as robust as in treated. And can it be because of a ceiling effect? The sicker patients have much space for improvement. That's why you are getting so many zeros in your p-values.
Yeah, that's a great question. I don't think it's a ceiling effect, because not all the patients, there's not that much asymmetry between the eyes. I try to do the worst eye because it's going to show the most improvement, but there usually isn't that much asymmetry. It's usually fairly symmetrical. But there are two ways I can explain. Well, there's 3 ways you can explain the improvements in the untreated eyes. One is a practice effect, right? They're just getting better at the test. problem with that is that all these patients have had many visual field tests over the years. They're very familiar with it. They're kind of past the practice stage. That's one thing. The other thing is that the improvements in the treated eyes are several magnitudes bigger than the untreated eyes. It's not a little bit. It's like 1,000 times more improvement in the treated eyes. Okay, so why would that be? There are basically two things. David Kent was part of a fantastic study years ago with Maria Grant, where they treated mice, and when they treated mice with basically SDM, about 3 weeks after treatment, they noted bone marrow immune cells. If they treated one eye of the mouse, bone marrow immune cells came from to both eyes as a result of treatment. Treating one eye stimulated a systemic immune response, okay, which is fascinating. And the immune response didn't really know which eye was in trouble, so it went to both eyes. And David can elaborate on this in a minute. So that's a possibility. However, I do note that was noted about 3 weeks after treatment, which would be not quick enough to probably explain the fellow eye improvement here. The other thing that may be going on, and I think is more likely actually, is that there are efferent nerves in the optic nerve and in the retina. There are actually, we always think of the afferent nerves that are going back to the brain through the optic nerve, but they're actually nerves from brain and from the other eye that go to the other eye and go from the brain to the eye. And years ago, there was a study out of University of Texas, and I can't find this study, but it was a fascinating study where it showed that if there's visual field loss in one eye in glaucoma, that visual field loss in the fellow eye very seldom involved the same area of the visual field. And what this suggested that the field loss was under some degree of CNS control, in that there was a very clear phenomenon where if a patch was lost in one eye, the other eye did not lose field in that same area, so that it would maintain the maximum function, binocular function. The other eye would sacrifice visual field someplace else. So we know that the eyes are actually communicating with each other. Okay. And so I think somehow that's the mechanism that makes the most sense, because this is a very rapid response. For in the visual field test, we're talking most of these patients were retested in a week. Okay, so there's not a lot of time for immune response to take place. There's this kind of stuff. It's only a week has passed. And so as David also alluded to, a lot of the improvements we get with SDM are immediate as far as proteostasis improvement and all that, metabolic improvement, but some of them take weeks and maybe months. But these improvements were seen only after a week, where the only explanation I can give for the fellow eye so the fellow eye isn't being directly affected, so we're not going to see metabolic improvements necessarily and proteostasis improvements, all that in the fellow eye like that, but unless it's communicated somehow by efferent nerve pathways.
Well,
any other questions or comments?
So I think, Lorenzo, do you have a question, please?
Yes. So excellent work, and also the liver is very interesting. I just wanted to know more about the RNFL thickness measures. Usually, these linear trends graph come with the p-value themselves in the graph to effectively perhaps it's done. Yeah. How many of the patients or treated eyes came with a significant p-values for the linear trend in the eye itself? On a
p-value, virtually none. It's very difficult to get them to that level. So I'm showing you these are the kind of patients and the kind of trend tracings that we used, where they were fairly collinear and we didn't have a lot of scatter. This is what was used. So it's a good point.
Okay, I understand. I was asking because when we work with RNFL thickness, it's really also difficult sometimes to segment the layers. So it's I just wanted to ask you this.
Yep.
Thank you.
So I think, another thing for discussion here quick is how do we know this is reflecting neuroregeneration? Because so when we talk about thinning of the nerve fiber layer and the ganglion cell layer in glaucoma, which is usually inexorable, the reason for that has always been posited as loss of ganglion cells and therefore loss of axons. So what is it when we see now we reverse these trends? The simplest explanation is, well, we're getting more ganglion cells and more axons, which is frankly kind of hard to believe. But there doesn't seem to be a better explanation for it. Why do we see the nerve fiber layer thicknesses increase more frequently, like 75% of the eyes, as opposed to about 40% ganglion cell layer? Well, one reason is the ganglion cell layer is much thicker than the nerve fiber layer. So improvements are not going to show up as easily in the ganglion cell layer because it's so much thicker. There was something else I wanted to say, but I blanked on it. And there are several ways that could be causing neuroregeneration. One is by activating and differentiating stem cells. Heat shock protein activation is known to do this. The other is by modulating micro and macroglia. There's a number of mechanisms that SDM elicits that have been shown in other settings to be able to activate and differentiate stem cells. It could also be that the main effect here is simply kind of reperfusion of inactive axons. When ganglion cells get sick, they may survive, but they may shut down their axons. They may just kind of retract and no longer function. And so what could be going on here is that the ganglion cells are not actually increasing, but they're just simply reactivating, reperfusing the axons, and that's accounting for these thicknesses. That would still be defined in general terms as neuroregeneration.
Yeah, I would agree with that, Jeff. We've always interpreted thinning of the layers as atrophy. Well, atrophy in our minds means non-reversible. It is dead and cannot be reversed, but I think you may be correct.
Jeff, so in theory, you should be seeing the same in all patients treated, irrespective, in diabetic, in AMD patients. Have you measured those? Can you go back and measure?
Igor, your check is in the mail, because that's the thing I wanted to mention I forgot. Yes, you're exactly right. So we also have data showing that these same nerve fiber layer and ganglion cell changes we see in the patients with dry AMD. In a dry AMD, they actually improve more, and they improve more frequently. Okay, so these improvements in ganglion cell layer thickness and improvements in nerve fiber layer thickness are actually more pronounced in dry AMD than they are in glaucoma. Okay, problem, we didn't include it in this report because we can't get any dry AMD controls. Trying as hard as we can't find nobody out there does nerve fiber layer and ganglion cell layer thickness trends on dry AMD patients. So we can't get controls. But in our data, the AMD patients actually improve more. That makes perfect sense because, as Igor's question alludes to, it should do this in everything, and it does. It's at least everything we've measured, which is glaucoma and AMD. Why do the AMD patients improve more? Well, it's because they don't have glaucoma. Okay, so the glaucoma is going to work against these improvements. All right, but you're exactly right.
David has a hand up as well.
Yeah, no, Jeff, I just want to say thank you. Yeah, you've covered everything there, and it also, I think the beauty of the immune system is, it wants to fix stuff. So wherever the trouble is, it'll go and fix it, regardless of what we activate it for. So if it's a glaucoma patient with AMD, geographic atrophy, it'll just sweep that up in its reparative mode. And this addresses to your whole concept of anti-fragility. The greater the challenge, the greater the response will be in the presence of SDM. And the other thing, I agree, there is evidence now that cells, when they're in say, a hypoxic state or in the presence of elevated intraocular pressure, they do go into survival mode. And I think once you create the permissive environment for those to wake up, they will start functioning again. But just one question, and you kind of touched on it, if you like, and it doesn't do the whole thing, but the one cell, obviously, that straddles the whole neurosensory retina is the Macular cell. And I know you talked about the macroglia. That's one thing that I haven't really figured out. Do you have any thoughts on that? How that, because, you know, we talk all the time about histopathologically gliosis in the neurosensory retina, but we never really see it clinically because we can't visualize it and we don't have the imaging techniques to really image it in real time, or certainly in our clinic. I'm just wondering, did you come across anything in relation to the Macular cells? We're really beginning to appreciate its role more and more now.
Yeah, I know next to nothing about it. I know this much, that microglia and macroglia and Macular cells or macroglia, they basically have two modes of operation. One is the one mode, and the other is the two mode. One mode is the predominant mode, and it tends to be degenerative in aging. That's why we age and get worse. It's actively kind of bad for us anatomically and functionally. The two mode is actually the opposite. It's the same cells, but they flip over into a restorative mode of activity. Okay, and so conversion of by using laser to convert the microglia and the Macular cells to this two mode, the restorative mode, may well be active here. Okay, and in that aqueous proteomic study that Medina did, is one thing they showed in diabetics is after SDM, they showed evidence of Macular cell activation flipped to the two mode. Okay, the restorative, the positive mode. So we do know that laser does that. Okay, is that enough to account for neuroregeneration? I don't know, but it's very likely going on.
Yeah, thank you.
Oh, and one other thing about that comment, David, is that why? Okay, conceptually here, the peripheral nervous system regenerates, central nervous system doesn't. And this, okay, so how could we be inducing regeneration in these cells? And I think it may be along the lines of what David just mentioned about this fragility thing and the importance of function, in that there's some reason central nervous system cells don't regenerate. They're genetically identical. The difference is obviously then epigenetic. It's about gene expression. Okay, and so when we think about how SDM works, it always normalizes function. Whatever's wrong, whatever's abnormal becomes more normal across the board by every measurement, no matter what you do. Okay, normalization. And so when we think about what's going on here, we have functional loss, we have visual field loss, we have vision loss. The brain knows this because it's getting input. Okay, and so one reason that SDM may cause this epigenetic override of the prohibition against neuroregeneration in the retina is simply to allow restoration of function, which is the kind of the primary imperative. Okay, so it's a very interesting, almost a metaphysical consideration here about why we're seeing this. But the fact that we are seeing it is very clear and pretty dramatic.
Thank you.
Igor's going to just review the Diamond trial for us and just open up for a little discussion. Hopefully everybody's familiar with the paper and the results, and he's going to refresh our memory. Go ahead, Igor.
Yeah, thank you. So far, excellent discussions and presentations, excellent learning point. We have decided to include this journal club to stimulate discussion and maybe form, another hypothesis, start another projects, collaboration, and so on. So this one was actually suggested by Steve Sinclair, and it talks about the comparison of subtracheal micropulse laser to standard laser in diabetic macular edema. And this paper was published in Journal of Ophthalmology. So this was a randomized non-inferiority clinical trial, and it comes from the UK authors. And This Diamond study has several reports now, and they are being considered, to maybe influence NICE guidelines, in the UK. So basically, the purpose of this trial was to determine safety, effectiveness, and the cost effectiveness and everything else, while comparing subthreshold micropulse laser to standard continuous wavelength laser for diabetic macular edema. But this was an edema with central retinal thickness less than 400 microns. So this was a pragmatic, multi-center, double-masked, randomized, non-inferiority trial. So I looked up pragmatic trial, and it's actually a trial designed to help choose between care options, as opposed to explanatory trial, which is used to test research hypothesis. In other words, it's a real-world study. So the participants in this trial had to have DME of less than 400 microns and best corrected visual acuity of more than 24 ETDRS letters, which translates into better than 20 over 320 vision. Randomization was 1-to-1. So one patient received standard threshold treatment and one received subthreshold treatment. The retreatments were allowed, and the retreatments had to use the same mode of retreatment. Now, there was also rescue therapy that was allowed if certain criteria were met, and that was a loss of more than 2 ETDRS lines, which would be 10 letters, increase in central retinal thickness to more than 400 microns, or if one of those occurred. Now, what were the primary outcomes? The primary outcome was mean change of visual acuity between baseline and 24-month follow-up with non-inferiority margin of 5 ETDRS letters, which would be 1 line. There were multiple secondary outcomes, which included mean change from baseline to month 24 in binocular vision. We already heard something about it. Central retinal thickness, that is anatomic outcome, then mean deviation on Humphrey visual field, percentage meeting driving standards, which would translate to 20/40 ETDRS vision, then various questionnaires on qualities of life, then analysis of adjusted quality of life years, and the rate of adverse events, and number of laser and rescue treatments. So multiple secondary outcomes, 1 primary outcome. Now, this is important for our group. And so the subthreshold micropulse therapy used 577 wavelength by Iridex, and they used 7x7 grids. So they applied 4 grids, 500 microns away from the center. And these grids, so they were above, below, and nasally and temporally from the macula. They didn't treat the macula. Laser magnification was 1.0. And then they used 200 micron spot size and 200 millisecond exposure radiation. They used outside area for titration, and basically they were increasing power by 10 milliwatts starting from 50 until the tissue reaction was visible. Then they switched to 5% during cycle. So pretty much what Iridex guidelines are saying, and then the resultant energy was multiplied by 4. So for instance, if the threshold, barely visible threshold would be at 70 milliwatts, the final micropulse energy would be 280. Standard laser therapy basically is what has been known, and it is a laser to thickened area or macular non-perfusion. It's basically modified ETDRS protocol. Okay, so now what were the results? This is comparison of baseline compared to 24-month for both treatments, and that is both for intention to treat and per protocol analysis. And in both groups, the vision improved. And we see by how many lines the vision improvement was statistically significant. Again, for repetition, per protocol means analysis of eyes that finished the trial, and intention to treat is the analysis of eyes based on their randomization protocol, irrespective of whether they dropped out or changed the treatment. Now, we are getting to secondary outcomes. So we know that this treatment improved vision, and now this is comparison between these two treatments. And it says that mean change in binocular BCVA between baseline and month 24 was non-significant between the two laser modes of treatment. The same holds true for central retinal thickness, Humphrey visual fields, percentage of people who were able to drive while receiving this treatment. The only difference was in the number of laser treatments from baseline to 2 years of study, with more treatments received in subthreshold micropulse group. And that is 0.02 significance. All other parameters show no difference. Now, this is a table from supplemental data, and basically, because we are interested in laser therapy, this is the comparison. So spot size, actually, most of the eyes stayed with 200, which was a preset spot size. Duration 200, again, as was preset. So the laser power was higher in micropulse group, as well as number of spots, which is what usually happens. Now, the number of retreatments, here we can see some difference in the proportion of how many treatments were given to patients and proportion of patients. So in conclusion, these diamonds trials show that subthreshold micropulse laser therapy had comparable efficacy and cost to standard laser therapy, suggesting that either treatment could be offered to patients with central involved diabetic macular edema of 400 and less than 400 microns, sorry for the T typos, for macular laser therapy. They go on further to explain that this treatment should be easier and safer to perform, and they suggest that perhaps allied non-medical staff can be taught to perform that treatment, to fill in the gaps that needs to be filled and treat these patients. And so basically we have this non-inferiority trial that showed no difference between these two treatments, and I would like to open the discussion if anybody wants to comment on this trial or on the design, methods, outcomes. So Jeff, back to you.
All right, we've got Maurizio and Jeffrey with hands raised.
Oh, well, Igor, once again, I wish to congratulate on this wonderful study. And what about the time you need to complete the treatment? This could be a difference between the two different approaches. And in addition, what's your choice in case of a DME greater than 400? Do you combine anti-VEGF or steroid treatment and laser?
Yes, thank you, Maurizio. So, I think we need to go back a little bit to history where this 400 comes from. I believe there was a study by Bert Glaser, in one of his studies, he published that, micropulse, works in macular thickness less than 400. It's more difficult if it is more than that. Then there was one of these DRCR trials that Paul Mitchell used to present. And also if the thickness was less than, I believe, 300, that the laser was equivalent to anti-VEGF therapy. So somehow people, hold on to this 400, and I believe that that's why, this was selected as a cutoff point for this trial. As you know, that we may have difficulties assessing the outcome of treatments when we look only at anatomy, with the micropulse treatment, and for that reason, I have a tendency to start with injections if I need fast resolution of massive macular edema. And again, it's usually monotherapy first, and if the edema is not going away, definitely combination therapy. But here we have evidence that anything below 400, and some people may not believe that it's only 400, anything below 400 can actually be safely treated with micropulse laser with improvement in visual acuity. Is it okay, Maurizio? Does it answer your question?
Sure. Thank you for your kind explanation.
Thank you. Jeff? Is now then Steve Sinclair?
Igor, Igor, excellent. I read this article and I was, again, I'm a little bit concerned because with the standard laser, you're creating all kinds of defects within the visual field that influence the ability to perform visual tasks as just opposed to visual acuity. But in this study, do you know if they evaluated intraretinal fluid versus subretinal fluid. In other words, intraretinal fluid has been thought by a number of studies to affect vision more because it separates the neurons, possibly with the inflammation of the edema, within the edema, of also degenerating the axons and the dendrocytes and stuff that connect the neurons. I just want to know, was there any hint in this study of
thank you, Stephen. Yeah, they don't report on that. They just report on central retinal thickness.
Yeah.
These reports are still coming out. Actually, the cost-effective analysis was just published, so it's likely that they might look at it at some point, but in this report, it was not differentiated between compartments.
I think that's where we have to go with macular edema, especially the diffuse, is we have to look at the interneuronal layers as well.
That is correct. That is correct. And with respect to focal treatments, I agree. I believe that they used modified ETDRS, and for grid treatments they went lower on energy, and actually the energy, the power level was lower in standard arm compared to Micropulse. But again, that's the calculated power.
Yeah.
Jeff? Okay, so. Well, I think this is an important study because, it...
Igor, can you hear?
Yeah, go ahead. I'm sorry.
Did you hear me? I was talking and I was
Oh,
muted.
no, we couldn't hear you. At least I couldn't hear you.
Okay. So in the protocol, you noted that they used 3 7x7 grids, but then later it says that they treated the areas of retinal thickening. So it seems like there are two different things, okay? If they're
So what they did, that was, standard grids. If there was additional retinal edema apart from those 7 grids, they treated that additionally.
Okay, but if they had the 7 grids, 7x7, you can imagine they didn't treat the fovea, so they did kind of like above and below and maybe temporal, like a C-shaped grid.
Correct.
Okay, but if they only treated the areas of swelling, that might not have been that whole area. So did they just treat the areas of swelling, or did they treat this C-shaped area in every eye?
No, they treated the C-shaped, and if the swelling was outside that area of 7x7 grid, they extended that area.
Okay, that's interesting.
Okay, Jeff, Igor, just very quickly, where is Micropulse going in expanded grids? Are you going outside the macula now in diabetic retinopathy and edema? Where are you going, you two?
Well, I treat the entire retina, but I mean, because it's retinopathy, and we can. But I'm going to go back to the paper for a second. The other thing is, I think the results would have been probably better if they'd also treated the fovea. The other thing is that, we now can treat these eyes without any retinal damage. Okay, and as everybody knows, I therefore define any laser-induced retinal damage as a adverse treatment effect. Okay, because it's not necessary. In this study, they said they had no significant SAEs. They had 2% of problems. They did not describe which treatment led to the problems, and they also did not define laser burns as being adverse treatment effects. I'm sure that's political. They didn't want to upset the people who were, wedded to standard laser and so on. But I mean, just an observation. I think it's a little disingenuous at this point to say that, and I've seen a number of studies come by in the last couple of years where they say there were no adverse treatment effects, even though they're showing retinal burns all over the place.
Right. So usually you consider adverse event if it is close to the fovea, or if somehow it affects, perifoveal vision or BCVA. I'm sure there were some burns, but probably they didn't consider them important because they were not close to the macula.
Yeah. Anybody else?
So do we agree? Was this well-conducted study? Would you Do you agree with the conclusions?
I think it was a pretty good study. I think he could have, my complaint about all these studies is they usually don't do enough treatment and are often flirting with danger as far as burning the retina. But I mean, I selfishly view it as confirmation of my first report in 2005, 18 years later, that it does work for diabetic macular edema pretty well. I think they could have improved the results by kind of following light guidelines a bit, but I don't have too many complaints about it. Anybody else have any thoughts?
Again, I think if we have to move away from standard laser photocoagulation, we have to stop focusing on best corrected visual acuity or contrast sensitivity. And I would agree with Jeff, we have to treat the fovea with sublethal therapy and micropulse, and we have to treat quite wide ranges that don't create burns that are going to affect visual function, but not be defined by best corrected visual acuity. That's my own opinion.
Yeah, totally agree. And we should probably treat much earlier than what we are doing. And because there may be some imaging techniques showing us that the damage has occurred before the macula becomes swollen, and if we want to reverse the process, then it's perhaps advisable to intervene earlier than that. But I think that this is a good study again to show that there is an alternative treatment to standard laser photocoagulation, which has other advantages. And, the tone of the conclusion is actually making me believe that there might be a trend to switching to this kind of treatment.
Yeah. Oh,
Yes.
just one last comment, just to echo something that Igor said about the threshold of 400. It is an arbitrary threshold, and we really are focused on visual acuity in our patients, not so much thicknesses. The patients don't care about how thick it is. By the time somebody's got 400 microns of thickening, it's usually been there for a while. And so it's not an emergency. So I've had real good luck treating patients with a lot more thickening than that, starting with Micropulse and giving them a little bit of time for the visual acuity to improve and all that. And approaching it that way it's harmless, done correctly, so it makes sense as a primary treatment. And approaching it that way, I virtually never have to use anti-VEGF in diabetics. So I think if I had a patient with 500 or 600 microns of thickening, I'd still start them on Micropulse. If I couldn't get them to 20/40 or better and see some improvement within a couple of months, then I might give them an injection, but I don't feel like I need to give them an injection immediately unless they've got some urgent need to try to see if the visual acuity is very poor or something like that. That's all.
Jeff, just to follow up on that just real quickly. So if you have a patient if you have an eye that has quite thickened, especially foveal or parafoveal cysts and stuff, and you're sort of thinking about combination of treatment and can we reduce the number of intravitreal injections, do you start with Micropulse and see what kind of an effect? And then how soon, have you ever considered dual therapy? I've asked a number of docs and I've asked a number of pharmaceutical companies, and they've just never, you don't see any reports.
Oh, yeah. I mean, combination therapy is fine. It works great. I just tend to start with Micropulse because it's safer. Okay. And I usually let visual acuity determine it. If the visual acuity is bad, I want them to help. I want them to see better. So I'll often start with a shot just because I want to improve their visual acuity. And then I'll go to laser. If their visual acuity is not awfully bad and they're getting along fine, I'll start with laser. I let visual acuity determine. But that's all. But they're complementary. But drugs are short term. They wear off and it comes back. Laser is long term. You want to get them off the shots and use laser to get a long term effect. That's my philosophy on it.
I agree with you entirely. The pharmaceuticals are single component, single mechanism methods of trying to approach this multi-component, multi-effect, multi-oxidative as well as inflammatory disease process. I agree.
Okay, let's move on to the last talk. Hopefully you can see my screen here. Can everybody see?
Yes.
Okay, good. Let me get it on to the home. Okay, So this is a paper that we just recently.
Interest in our study. I recommend taking.
Oh, hang on. This has got audio. Okay.
Interest because.
Excuse me. You got to stop that. Okay. So I'm going to just use this view because otherwise you're going to hear narration. Okay. So this is looking at vision protection therapy, which once again is just continuing SDM on a regular basis in chronic disease to try to reduce the risk of reduce progression and the complications. And so we talked about a lot of this already. We published a number of patients in AMD using SDM. The first one, we showed that SDM reverses drug tolerance to anti-VEGF in wet AMD. And because tolerance is probably an epigenetic phenomenon, the effectiveness of SDM here is epigenetic modification, which then gets us back to the neuroregeneration thing, and which is very likely the same kind of mechanism. It improves electrophysiology, visual acuity, microperimetry, mesopic visual function, contrast visual acuity, all these things, every measurable index in dry AMD and inherited retinopathies. It slows geographic atrophy by an average of about 47% per year. And in that study, lesions smaller than a disc diameter were actually slowed twice that much, although we didn't have enough to get statistical significance on that. And we published two previous papers on neovascular conversion. One was an all-comers study of patients in my practice, which showed the expected incidence of conversion was reduced by between 95 and 98% per year. And a second was a real-world data study using ICD-9 data, where SDM reduced conversion compared to a national database by a hazard ratio of 13, which means it reduced the incidence of neovascular conversion by 1,300%, which is pretty robust. So because our last real-world data study used ICD-9 codes, we couldn't stratify AMD severity. ICD-9 just said wet or dry. It didn't give you any detail. So we repeated that study using ICD-10 codes, only ICD-10 codes. So we had early, intermediate, and then advanced dry with extrafoveal and subfoveal geographic atrophy. We got more detail. And we looked at all the risk factors, and we compared standard of care, which is kind of everybody else, to vision protection therapy in my practice and with my associate at the time doing the treatments. We got the data from Vestrum. There have been a number of studies from the Vestrum database published on various things. It's a great resource. And this study window is a 6.5-year study window, so pretty long time. So we started with 500,000 eyes that were then filtered and matched by propensity scoring. And for those who don't know, propensity scoring is a way of taking an existing population and randomly matching them like you would in a randomized clinical trial to get very robust statistical comparisons, okay? So the statistical validity of a propensity scored study is comparable to a randomized clinical trial, but because you've got a real world data study, you can have tremendously larger patient populations. So the patients were compared to 1:10 ratio because there were far more patients who did not get laser than got it. And and since there were only 814 VPT eyes during this time, and this is once again patients who only had dry AMD, nothing else, no other eye problems, compared to 8,000 randomly selected but matched control eyes. The standard of care patients, interestingly, had a shorter average follow-up and far fewer patient visits and encounters with the doctor than the VPT eyes, because we were treating the VPT eyes every 3 months, and very few, if any, retina doctors were seeing their dry AMD patients that often. So in this study, the neovascular conversion rate was markedly lower once again in the VPT treated eyes, this time by a hazard ratio of 6. The higher the risk factors, the greater the benefit. This is the opposite of the nanosecond laser trials, I forget the Geimer's study on LX. where they made the worst eyes worse. We actually did 4 separate analyses in this study. One was just simply propensity scored, taking the populations and comparing them, and the other we did because of the reviewers really didn't understand propensity scoring. They at their insistence we had to do some post hoc examinations. There were a few eyes in the VPT group that weren't treated because they had very early AMD and they didn't need treatment, and so we excluded those in one post hoc and another post hoc. Others we balanced the number of visits between the patients, because unbalanced, the VPT eyes were seen an average of 13.2 times during the study, whereas the standard care patients were only seen 8 times. That's a little more than once a year. When we looked at just the overall, the conversion rates in the standard of care eyes, it should be SCA, was about 4 times higher, and with a hazard ratio of 6 than the VPT eyes. EF here means examination frequency. When we tried to balance the examination, you can't diagnose wet AMD if you don't see the patient. And one of the issues with the standard of care is they don't see the patients very often. So if you don't see the patient, you can't diagnose it. We tried to balance out the number of exams between the groups. The best we could do was to approximate them, because the standard of care eyes patients were just not seen nearly often enough to actually balance. But for every 1% increase in the exam frequency in the control group standard care eyes, conversions increased by 1%. So what the upshot of that is that this very robust hazard ratio advantage of vision protection therapy, reducing conversion by a hazard ratio of 6 in this study, actually underestimates the real effect by possibly as much as half, because so many of the patients in the standard care group are not accounted for. They're just not seen that often. Here's just a quick graph showing the advantage. The top is how often they converted in standard care. The bottom is conversions in the VPT eyes. Propensity scoring, if you do a quintile analysis, this is able to detect any unknown bias in the analysis. And the groups are divided into 5 groups based on their similarity and matching. And we see that the vision protection therapy has a tremendous advantage over standard care in every group, showing there's no kind of hidden bias. So this shows the total conversions. One of the interesting things is a statistician, I didn't ask him to do this, but he did it anyway. He looked at the number of injections in patients who converted after converted. And what he found was that the injection rate in post-conversion eyes was significantly lower if they continued vision protection therapy, which is what we've seen in other studies. The problem with this number is that there were so few conversions in the vision protection group that the numbers has some limited meaning. Okay, so what we see is that vision protection therapy markedly reduced conversion. It's virtually identical results to 2 prior studies, and this one had 4 different analyses, all with identical results, which statistically is very meaningful. Standard of care, one of the big problems is it frankly misses the majority of patients who convert simply because they're not examined. And VPT appears to markedly decrease the number of injections post-conversion, which was what we've seen before. So basically, VPT seems to be an extremely effective treatment in dry AMD by slowing progression, improving VA, prevents conversions, lowers injections. And at this point, with the number of large studies we have, I think you can be pretty confident in the data. Okay, so any comments and someone for discussion?
So, Jeff, what you did additionally, what the reviewers asked you to do, was it just the sensitivity analysis? You mentioned that they didn't understand propensity scores, and they made you do something additional.
Oh yeah, well that's what those are the post hoc analyses. Propensity scoring is once again a way of randomly matching populations, right? And so the reviewers wanted the eyes that had not had vision protection therapy excluded. Well, the statistician doesn't like that because that then becomes a post-randomization modification, which then basically invalidates the statistical analysis to some degree. So intuitively, you say, well, why include these untreated patients in the analysis? There were 9% in the visual protection group, and it's basically to preserve the randomization. Once you change that, then you lose the randomization effect. But all of the other factors remained. And so, and further, if we look at the strictly propensity scored analysis without any adjustments to the other analyses where the exam frequency and the presence or absence of untreated eyes in the VPT group were there, all the results were really virtually identical. So it made no difference. Yeah.
That's amazing. You know what? I am more and more interested in the CNVs that occur following certain treatments, be it GA treatment or laser or what previously was presented by Mauricio. And I know it may be a little bit off topic, but I would actually like to look at those CNVs, like their characteristics, if there would be a way to pull them together and maybe, again, do reanalysis of a number of injections and, compared to standard, neovascular membranes.
Something that's interesting is Diaz and associates from Bascom Palmer a few years ago published an OCTA study, and they found that I think it was about 15% of dry AMD eyes had pre-exudative CNV. They found CNV that were not otherwise detectable except by OCTA. Okay, and of those, I believe that within a year or so, 60% became active and showed leakage. Okay, so in our studies, with vision protection therapy approach, SDM repeated on a regular basis, we see a conversion rate we see a conversion rate tremendously lower than that. Okay, so you can be assured that a lot of the eyes that we've treated in this study have pre-exudative CNV that you could probably identify by OCTA, except that they don't leak, and we keep them from leaking. So one of the things that's going on here clearly is that not only does it prevent new choroidal neovascularization, it also appears to prevent existing pre-exudative neovascularization from becoming active. It suppresses that.
So that's very interesting concept. So we actually did some studies on simultaneous GA and CNV, and again, before OCTA, which is much superior imaging modality compared to fluorescein, which fluorescein just stains everything. With OCTA, you are detecting many more of those. So before OCTA, you would see like 3% of CNVs present in eyes with geographic atrophy. Now we jumped, like you say, to 13%, even up to 16%, and yeah, we are looking at them more carefully. And at some point, actually years ago, we did a study where we looked into genetics of those. And that was with somebody who discovered HTRA gene, one of susceptibility genes for the wet AMD. And we compared eyes with CNV with GA and combined, with simultaneous GA and CNV. It was like 300 eyes. And actually, they didn't find any genetic difference, and they looked very carefully. So I remember the guy telling me that, GA and exudative AMD are the same disease genetically. They may be phenotypically different, but genetically it is the same disease.
Yeah, I would expect so. And there was a study last year on GA showing that genetic differences didn't have any effect on GA progression. You would have thought that people with more risk factors would progress faster. It's not true. In fact, when we did our GA study back in 2020, one of the things that was really interesting in it, although it slowed average progression by 47% a year, which is much higher than the complement fixation or the complement inhibitors. It also prevented CNV, which is very different than the complement inhibitors. But what was very clear, actually looking at the data, is that the individual patient variation in rate of progression was extremely variable. Some patients just progressed like crazy, others hardly progressed at all. It was a very patient individual phenomenon. And if genetic predisposition does not account for that, then it's just got to be multifactorial, all those kind of things that we think of in regard to AMD.
That's fascinating. Again, I would like to learn more about those converted CNVs following the treatment, any kind of treatment, not just that spontaneously convert, that's natural history, but, the eyes that had received treatment and converted to AMD, what do we know about those membranes?
Yeah. Is anybody else treating dry AMD?
With what? With laser?
Yeah, like this.
I tried, and again, the patient would say like, "Oh, I thought it was brighter." Then I tried second time, and they say it's brighter for a week, and then they expected more, or I didn't explain enough, or I expected more, and I'm not. I treated like 4 or 5 patients.
Yeah, I treat as maybe a few thousand patients, okay, and I've been treating pretty extensively for almost 10 years. And what I tell patients is I tell them not to expect any improvement in their vision. We are not treating them to improve their vision. We're treating them to reduce their risk of vision loss, and primarily by reducing their risk of getting wet AMD, because that's what we have very good data on. And so a lot of that is all about creating appropriate expectations. And my favorite analogy is high blood pressure medication. When you take high blood pressure medication, you don't feel better. You just don't have a stroke. Okay. This is the logic behind it. And people understand that, and they get it. And another thing is in a disease that progressively worsens, if they're not getting worse, they're getting better in a real way. And these are ways to help patients understand it. As far as that, it's very interesting, that bit about brighter early on. Very commonly, you will hear, especially patients with AMD and so on, will say that their vision brightens, improves right after treatment, and it lasts about a week or two. Interestingly, if you do any kind of testing on them, if you do mesopic visual function testing, perimetry, electrophysiology, you name it, you will see improvements within 24 hours. I think the earliest testing I've done is 4 hours and seen improvements. And those improvements will generally hang on for at least 3 or 4 months. Okay, so how do you explain this subjective sudden improvement that then goes away in a week or so? Okay, there may be something going on that literally only lasts a week or so. But what I think is far more likely is that after a week or so, that improvement becomes the new normal, and they simply no longer notice it, appreciate it. It's just kind of how it is. They get used to it. It's the change from the situation before to the new vision change after treatment that really gets their attention. And
you mean they are getting closer to ceiling?
Well, I mean, they're just getting accustomed to it. When you treat them, they suddenly see this improvement, but after a week or so, that improvement is the new normal. It's just it's like anything else. You have steak every day. After a while, steak gets kind of boring. It's just human nature. They get used to it, because if you test them any way you can imagine, those improvements are still there. So if the patient doesn't notice them after a while, I think that's just psychology. It's just that they're getting used to it, and it's not a big shock to them anymore.
Yeah, I agree. We are very far behind in visual assessment of vision.
Another thing that comes out of this study, it's interesting, is if you look at patients with intermediate AMD or across the board in this, after 5 years in the control group, almost 60% converted. Okay, and that's even with the very marked underestimation of conversions in the control group, as opposed to less than 10% in the SDM group. So that's a pretty, you know, I think the other thing is going on here is that the natural history studies, the statistics that we tell our patients, like there's a 3% or a 5% or a 10%, you know, risk of conversion in this amount of time based on what they have. I think those are vastly underestimate the actual risk. Because when we look at what we find in this study, the conversion rate is much higher than that. And this is one of the biggest real world data studies ever done on dry AMD. You know, starting with this, as many eyes as we did, and so on. And I think and that's even in the context of not accounting for probably at least half of the conversions. Okay, so the risk of conversion in most people is over time is much higher than we tell people, and which makes it that much more important to try to reduce that risk. So I think SDM Vision Protection Therapy approach of regular repeated treatment to maintain the effects is extremely effective, and people should consider it. I think there's adequate data out there now to justify it.
Jeff, do you have the data of something like this number needed to treat type of thing? Can you derive the,
like for a clinical trial?
No, from this study, you know, like to prevent an event.
Oh, I mean, I'm sure we could derive it from the study from the data. We didn't do that, but it wouldn't be a very big number. If you go to the journal, we have the statistical analysis is 100 pages long. Okay, and
that's why I'm asking you.
Yeah, supplemental data. We did not look at that specifically, but I'm sure it could be derived from the data we have, but it wouldn't be a very big number.
Because that's what you basically want to accentuate, you know, if you want to highlight the importance of this therapy, wouldn't you?
That would be another way of doing it. I think these are pretty convincing results by themselves, but there are many ways you could look at it, and that'd be another way. Yeah.
Any other comments, questions, Andrii, Lorenzo?
I beg your pardon, in very noisy place. I don't know. Do you hear me?
I'm having trouble understanding.
So, okay. I'm in noisy place.
Sorry, who's speaking?
Andrii.
That's Andrii. I think he's somewhere in the building on his cell phone.
Okay. Okay.
Yes. If you don't mind, I'll answer from later, maybe next day or next week. Okay.
Okay. Well, if we don't have any more comments, we can close the meeting officially. If you have any comments or so on about how the meeting worked, it's been, you know, it's very difficult to do these things live. This seems to have worked pretty well. We can try this again in the future if people want. We'll talk about it later. But I really appreciate everybody's participation and involvement. The meeting's been recorded. We're going to put it on the website. So if anybody wants to go back and look at slides in more detail or review something or have a friend to check it out, it'll be there. And hope everybody has a great day and evening and all of those things. Thank you so much for participating and for joining the meeting.
Thank you very much, Jeff. That was amazing, very fascinating and great learning opportunity for all of us. You all have a great evening.
Okay. Good night, everyone.